Welcome, everybody. Thank you for joining us. Mike, I'm going to go ahead and kick off the conference, and let's have some fun this afternoon. I'm Tobin Arthur, the founder of AngelMD, and we are really glad to have all of you here today. It's going to be a great event, and I just want to acknowledge a few folks before we get started. First of all, we have an incredible group of speakers and panelists, and I want to thank each and every one of you for taking time out of your busy day to join us today. I also want to thank the Clinical Advisory Board from AngelMD. We've got a great group. Many of them are going to be presenting and participating and moderating panels today. So you're going to get a sense of just the caliber of folks that are involved, and we're very excited about them. I also want to thank Mike Szymanski, who's executive producing this event. He heads up research and analytics for AngelMD, a 25-year veteran of Wall Street, and just incredible guy. So a lot of what you see today is really just Mike putting this on his back and doing the hard work. This is a follow-up summit to the one that we held in July, which was also terrific. And we will have another one in the spring, and Mike will reference that before the end of the day. As Mike will share, we have the day broken up into 5 different sections, each of them super interesting, great conversations. Mike will share some of the pre-event networking roundtables that we had and the content that's available around those. But we're going to kick it off today with a fireside chat with Matt Patsky, who I'm going to introduce in just a minute. And I'm really excited to spend some time with Matt and introduce him to all of you. I want to start, though, by just recognizing it's Veterans Day today, a really terrific day in our history where we can take some time and honor those who've served in our military. And I want to thank all of you who might be on this call or this event who have been who've been providing service in our military at one point or another. If you wouldn't mind mentioning that in the chat, we would greatly appreciate it. I don't want to embarrass anybody, but we do want to honor you. And we thank everyone who has served for their service. A very special day for us. I'm getting a little bit of feedback. Jennifer, if you can moderate that. I want to just talk a little bit about, create some context. Many of you are new to AngelMD and what we do. So just for a second, I want to talk about the fact that we are a huge community centered around healthcare innovation. Our goal is to create better outcomes for all of the parties. And we talk about how innovation is social. And today's a good representation of that. We think that we're all better, smarter, working together as a community. And so we do host events periodically. Our software platform is designed to connect our membership in various different ways. And all of this connection is designed to create outcomes. That's why we're excited about this particular event, because it's the Action Summit. We didn't just want to have an event where we learn something and have a good time, although those are certainly important outcomes of this event. But we want to create actionable items that are going to help entrepreneurs, help investors, and ultimately help patients in the process of all of this. So it's going to be a great event to try and do all of that. A couple things, just talking about our networking lounges after the event. These have been super popular, and so if you are able to stick around at the end of the day, these go for half an hour, 45 minutes or more. Our speakers are going to be joining in lounges that are designated. Mike will talk more about that. And Will Walker, and I want to recognize Will, who is with Hall Venture Partners, a great partner to AngelMD, and Will is just a fantastic guy. And Will is, in fact, how I met Matt Patsky. And so I want to thank Will for that. Will is going to be hosting a lounge for Hall Venture Partners, and Matt has become an investor and an advisor to the fund. And so he's also going to be participating in that lounge. And Will's going to share a little bit more about opportunity zones and some things that we just don't have time for today, but that are incredibly important for investors, particularly as we get towards the end of the year. So I want to encourage you to stick around for those lounges. A couple of asks. All of you startups that are on this in this event, those of you clinicians, family offices, venture firms. If you're not registered for AngelMD, please take 30 seconds and do so. You can do that at our website. Speaking of which, I want to give you a little bit of inside baseball. We have a new website that's about to go live. You can actually preview it. So our current website is angelmd.co. We really haven't modified it since before COVID. It's an incredibly long time as I hear that. But angelmd.com has the new site. And so over the next week, we'll be porting the old site over to the new site. But if you want to get a new glimpse, it helps create a much clearer story. And we're going to have a lot more resources, both for physicians, which are the center of AngelMD, and the startups, and certainly investors. Also, starting December 1, we are going to be doing daily briefings. These will go out every single day talking about what's happened in healthcare innovation in the last 24 hours. And we're excited about that. That will come out 5 days a week. It will complement our normal newsletter, which comes out every 2 weeks. Those are available for every member who joins AngelMD. You get those materials sent to you automatically. We will also be launching Alpha Creative in the next week. Alpha Creative is a marketing agency designed specifically for startups. We're very excited about this because we are really good at helping startups tell their story, but a lot of times that just requires distilling that story and figuring out how to share that for those of you who are figuring out how to lean in. And so we've got some exciting things to share over the next week. Finally, I just want to welcome all of you to look at Innovation for Alpha, our podcast, and subscribe to that podcast. And if you are a startup or an innovator, stakeholder in healthcare, we'd love to get you on the show. It's a really fun show, and it is centered around all things tech, innovation, healthcare, leadership, and we're driving some great traffic and encourage you to join in. So with all of that out of the way, I am really excited to bring to the stage Matt Patsky. Well, you see, I've gotten to know Matt. He's just an incredible guy. He's an iconic leader in the investing space, in the ESG space, impact. We can call it a number of different things, and I might pick his brain a little bit on that. Matt is the head of Trillium Asset Management based out of Boston. And as I mentioned, one of the foremost leaders in this space. So Matt, welcome to the event. I'm really, really glad to have you here with me today.
Thank you, Tobin. Happy to be here, and thank you to everyone at AngelMD.
Well, as I told Matt just a bit ago, he's got probably the best view in the house for this event there in Boston. I'm jealous. Matt, I want to start off just when you've got a short amount of time. Matt and I, every time we get a chance to chat, he's got so many great stories and history. We could go for hours, but we've got just a short time frame today. So Matt, you have had the moniker of the healthy guru of Wall Street. Can you just start off by sharing how did you get that nickname? Where did that come from?
Yeah, when I was a consumer analyst actually way back at Lehman Brothers, I started looking at environmental and social impact in the investment space, and started to incorporate that into the research I was doing on consumer brands, and it led me to a whole bunch of brands that were actually catering to healthier lifestyle trends, including Whole Foods Market and a whole series of players in the natural product space. And the moniker of Healthy Living Guru was something that was given to me by, I think, one of the investment bankers, and it stuck. And then we started doing a annual conference, which we called the Healthy Living Conference, that started in the mid '90s, and so it was kind of cemented there, and it certainly did me well in my career.
That's a good moniker. Matt, for those who are not familiar, maybe you can just tell a little bit about Trillium and maybe just a little bit of the brief history, because it really is in many ways the history of ESG investing.
Yeah, sure. Yeah. Trillium was started by a pioneer in the field, Joan Bavaria, back in 1982. And the objective was she had worked in a trust department of a bank and was demonstrating that you could incorporate your values into the investment process without sacrificing return. And so she launched the firm with the objective of providing for the financial needs of our clients while leveraging their capital for positive social and environmental impact in alignment with their values. And what that really meant was we're an active owner and we're pressing the companies that we do invest in for improved environmental and social outcomes. And that's true across the board in everything we invest in. And so we're now over 5 billion in AUM and over 6 billion in assets under advisement, and the firm has seen tremendous growth as we've seen, I think, recognition that the environmental, social, and governance information actually is material to the performance of companies and material in terms of managing risk and portfolios. And so there's the beginning of I think real recognition from the mainstream that they need to incorporate ESG.
Well, it's funny you mentioned it is getting more recognition from the mainstream, but that wasn't always the case, obviously. And you've told me some pretty funny stories about earlier in your career. You saw trends and you saw opportunities. And I love the fact that you just mentioned it wasn't just about social influence; it was social influence and doing well. That those two things were not antithetical. In fact, they were complementary. But maybe just go back and share a little bit of that early insight that wasn't as well received at the time.
Yeah, the initial look at how this was playing out in terms of the building of sustainable franchises in the consumer space was while I was at Lehman, and the one place I would stop first when I would go to visit a company was the HR department, and you'd get the same comment every time. No one in the investment space ever asks to speak to HR. And I'd say, no, I need an hour with them at least. So, and I'd start doing that deep dive of how they handle onboarding, what their compensation systems were, how they were doing in terms of turnover. Retention's obviously critical. Talent recruitment and retention is a critical part of the success of any business. But I had, though, taken all of that, gone back and decided I was gonna change Lehman Brothers, and I did a pitch to the associate director of research saying, I think I have a way to build the most incredible franchise that would translate into being the investment bank for socially responsible businesses. We should talk about environmental social impact across all sectors. And he leaned in and he said, Matt, it's really nice that you care about these issues. If you don't stop, it'll destroy your career. And so I made the decision then that I needed to leave Lehman Brothers. And obviously I left long before they had their issues, but I left them in 1993. But it was it was an interesting period of time, and certainly as I say to people, I wasn't wrong. I was just really early.
That's that's the story for a lot of startups, right? I mean, timing is critical, and history has proved you right. The market shifted, and as you indicated, this is becoming much more acceptable. Trillium's own performance and growth is a testament to that. You guys are growing like a weed worldwide. Can you maybe talk a little bit about in the current environment, what are some of the things that you see going well with respect to ESG, and then what are some of the areas that, maybe you're not quite as happy about or excited about that you would change, if you will?
The mainstreaming is really exciting because it's an acknowledgement of its materiality, and we're certainly seeing that both from investors and, of course, from the regulators. And the regulators are now starting to get into whether or not this should be regulated and how in across the globe. And of course, the most aggressive is what we're seeing out of the European Union. But I would say what's disheartening is how many players have decided that because it's a hot market, that they should slap ESG on the label and are putting out product that is not true to label. And so we're seeing, it's referred to as greenwashing, but we're seeing an awful lot of it where there's a lot of activity of mainstream organizations taking product, slapping ESG on that, and putting it out to the marketplace. And unfortunately, not authentic and not done in a real way, isn't really getting the benefits that are inherently there, because we do know that companies with stronger environmental, social, and governance profiles actually correlate with stronger management teams and correlate with better performance over time. So it's there. The evidence has been there for 40 years.
So I know in our discussions, Trillium, you take a very conservative approach, first of all, to performance and costs and fees. You're very conscious about those things. Can you talk a little bit about, for those in the audience that might be part of family offices or investment groups, how can they participate in Trillium's performance? And then maybe the same question specific to individuals. Are there opportunities for individuals to participate in Trillium's business?
Yeah. With our success has come a need for us with our direct business to raise our minimums. And so we now are at, while it might not seem insurmountable for some on this call, it's certainly insurmountable for the average American, is that our minimums now are 5 million to work with us directly. That said, we went around, we really took a hard look at how we were how we could make our services available to a broader range of people. And back in 2011, we began a campaign to work with the broker-dealer channel to get on platform to allow people to have access to Trillium strategies at much lower minimums. And so we are on, almost every broker-dealer platform you could imagine, from Merrill Lynch to Morgan Stanley to UBS to Raymond James and on. We're on most platforms, and we're on Envestnet. A matter of fact, I think now the number I think is almost 200,000 financial consultants in the United States have access to Trillium strategies. So that was successful in getting the minimums down in the range of 50,000 to 100,000. But we also launched in both mutual funds ourselves and with partners, so that there's an available way of investing in Trillium strategies through mutual funds. And so literally we've gotten to the point where we can reach people who are only able to put $1,000 into the market.
That's very cool. Want to just bring it to a specific in a few minutes left. You and I were introduced by Will Walker, as I mentioned, and you got interested in what Hall Venture Partners and behind the scenes Hall Labs was doing. And Will's going to be talking a little bit later as part of a panel and then hosting a lounge at the end of the day where he can share more. But would you mind just giving some insights into what you saw around what they were doing? Because it is very interesting in terms of there's a big impact story behind Hall Labs, and Hall Venture Partners is also taking advantage of opportunity zones and so forth. But just share what interested you.
Right. I mean, certainly the opportunity zone structure of it was helpful in terms of people who are looking at tax efficiency with rollover of capital gains. But what really intrigued me was the impact nature, and that was they were addressing a number of real trends in terms of electrification of the transportation fleet, the emergence of smart homes, and the need for more, I would say, smart devices in the home, particularly around healthcare. And of course, one of the attractive names that really got my attention was a company called Medic, and the need, particularly as our population is aging, to come up with better techniques for diagnostics with an aging population. And it was, I think, just sort of addressing a need that's there that particularly is prevalent in nursing homes and assisted living facilities, with a population that's less mobile.
Yeah, it's an incredible company. We'll provide a link for anybody that wants to see that smart toilet. I think it's medic.life, but really interesting company. Matt, is there anything that you would like to share just in thinking about, the year ahead for Trillium, or things that you're working on that you're excited about that would be worth kind of wrapping up the conversation with?
Yeah, I would just say this, because it's where I think the resistance comes, is most people have an inherent belief system that they come to when they look at investments of you can't look at incorporating your values into the investment process without sacrificing return. I hear it every day. It isn't true. There is the opportunity to think about your values and incorporate it into your investment portfolio. And what we've certainly witnessed, and over the last 40 years, is it would appear to be able to increase your returns, and there is no sacrifice. That is a false belief that I think we need to overcome, across the board, and recognize that there is the ability in incorporating your values to actually reduce risk in your portfolio and enhance returns.
We're going to put some information in the event notes to include links to Trillium for those of you who would be interested in learning more. Matt, it's great to have you. I really appreciate you taking time today. And if I understand correctly, you're going to join Will later in the lounge. So if anybody's got questions and would like to interact, it's a great opportunity to chat with one of the leading investors in the world in this space. So really appreciate it, Matt.
Thank you so much. I'll be in the lounge at 6 p.m. So thank you so much for inviting me today.
Really appreciate it. Mike, I'm going to turn the floor back over to you.
Great. Thanks a lot, Tobin. And thank you, Matt. That was fantastic. And I have to say, it really points out one of the reasons why we push forward with this Impact Action Conference. The reality is that so much about social impact investing is kind of this broad spectrum where it either turns into a marketing or a box ticking exercise. And we felt a need to take everybody that really wants to do well by doing good and invest in starting on these medical startups and focus them down in a thoughtful and attentive way onto concrete elements of each of these main channels that really mean something, that are really concrete priorities that we need to solve. And then distill from these priorities specific action points, which we'll be following up on in the months to come. More about that later. But to kick off today, I want everyone to know the structure of how we're going to be doing this. We have 5 independent channels. I'll discuss them in a moment. Each channel will have a lead speaker, which I'll speak with, and then I will introduce a doctor lead, which will come on. They will then lead the conversation between the lead speaker and the rest of the panelists as we, as I mentioned, distill these concrete priorities and then from them specific action items, which we will then send out with requests for companies and other solution innovators to then solve for these action points. And stay tuned very much after this conference, because that's going to be really amazing stuff as we bring together all of these topics and create this really focused, thoughtful way of solving problems and putting it out there to the public and to our innovative community. So with that, our 5 panels are kicking off. The first of the day will be mental health, health or wellness, depending on how you define it. The doctor host will be Karen Zuckerberg. She's an investor, advisor, and philanthropist working with companies, institutions, and healthcare, technology, and live events. She's a graduate from Brooklyn and the New York Medical College and pursued a psychiatry training at the Westchester County Medical Center. She's a special interest in eating disorders and addiction problems. After that, we will have the healthcare access and equality, led by my often co-host from Pitch Club, Katie Richardson, who's amazing. Katie is a pediatrician, experienced healthcare leader who had worked a lot in Kaiser Permanente across the wide range of different subjects, both up and down the cycle of innovation and healthcare services, including primary care operations, and Director of Philanthropy, as well as in the multidisciplinary team for innovation at KP. So the third section will be the innovation ecosystem, led by Dr. John Dayton, an experienced emergency physician and entrepreneur. He's the design fellow at the Stanford's Department of Emergency Medicine, and he is the president of the Utah ACEP and founded the Utah Society of Physician Entrepreneurs. I worked with John on a couple of different projects. He's pretty amazing. We're looking forward to all of them. Well, all of our docs are amazing. I shouldn't call John out just by himself. After that, we have pandemic preparedness with Kate Eisenberg. Dr. Eisenberg is a family physician and epidemiologist practicing in Rochester. She completed her MD PhD program in family medicine residency there, and she's been working in clinical informatics, so big data and how it relates to healthcare. Interest in population health, value-based care, analytics, informatics. There's a reason we called her in for pandemic preparedness, because data is so relevant in that space. Finally, closing out our presentations today will be Bridging the Digital Divide with Sindhu Pandit. Sindhu is a clinical leader in healthcare and life sciences team at Salesforce, and she is the medical director for the Oxnard Rehabilitation Hospital in New Orleans. Her clinical practice includes both inpatient and outpatient. We brought her in because, as an expert in Salesforce, we want her opinion on how do we bridge this digital divide? How do we bring healthcare up to the modern age, given they feel like we're 10 years behind in this space? So with that, I'm going to kick off the Mental Health Roundtable. So for the Mental Health Roundtable, just so you know, nearly 450 million people worldwide are currently living with mental illness, yet nearly 2/3 of those people with known symptoms never seek treatment. Mental and behavioral health issues must be treated as a disease, not as a weakness or personal failure. Our pandemic experience has brought additional attention to this important topic. So now join us as we explore the facets of mental health challenges, their solutions, and public awareness. So with that, I'd like to introduce Laura Blank. Laura Blank is the Senior Policy Associate at Wellbeing Trust, an organization that has been focused on both bringing awareness and solutions to the mental health space. She served as the public policy lead in the State Health Center for Policy and Performance. She's got 15 years of experience in health policy analysis and is working to transform systems and social structures to improve mental health outcomes. Laura, welcome. I'm sorry, that's been like a fire hose. I kind of thought I'd try to pace that down a little bit, but we're trying to stay on pace here. So Laura, so thankful that you could join us. Could you tell us a little bit about your experience with that state health department and what that taught you about applications and bringing together all of these solution providers across the ecosystem to try to address some of these problems?
Yeah, absolutely. Hopefully everyone can hear me and see me okay. Thanks so much, Mike. And thank you for inviting us to be part of this amazing panel today and for addressing this really critically important topic. I think, to answer your question, my training is in public health, and I've had the opportunity to work across a variety of settings. I've worked in the HPV and Cervical Cancer Research Center with the American Social Health Association. I've worked in HIV case management in the Bronx. I've done health policy work with the Texas chapter of the American Academy of Pediatrics to promote policy that focuses on children, family health, and the practice of medicine. And in the state agency setting, I've played a variety of roles, including within the Medicaid program, within the public health department in Texas, doing program operations and various public health policy. And I've been very fortunate and had a lot of exposure to sexual health, children's health, Medicaid. And the one common thread that runs through all of these experiences really has been the extreme need for mental health services, as well as a complexity with addressing those needs and the barriers to care. And so, I came to Wellbeing Trust in May.
Just a moment to that. Like, what do you mean by a common thread? Why is it a common thread in these different issues?
Even when you're focusing on, and I'll give you an example, when I was at the HPV and Cervical Cancer Research Center, and this will date me a little bit, but it was before there was a vaccine for HPV. So we're going back 20 plus years. I worked, we had several STD hotlines and two of them were focused, one on herpes and one on HPV, and people would call in. And our job was to provide information and facts about HPV and help people connect with medical services if that's something that they needed to do. And through the course, I worked a lot on this line. And through the course of many weeks, I noticed that there was somebody who called every single day.
They were just looking for attention at some point. They needed help, different kind of help.
They needed help. And it wasn't about HPV because I had given them the same information every day. They needed somebody to talk to. They had stress, they had worry, and it wasn't something that was being addressed in any other way. So they called. And there could be a variety of reasons for that, right? Like it was anonymous, it was safe, it was comforting. And, after a while, my boss was like, you really have to find a way to move this person along. And I was like,
I don't want to.
If it's helping them, that's what we're here for. And so, you see that across a variety of things, doing HIV case management. We were focused on making sure people were getting to their medical appointments and taking their medications. But the truth was, what they really needed was somebody to go with them to their end of life planning because it was too much for them to handle alone. And so, despite the focus of different things around, sexual health or children's health or, infectious disease, there is always a mental health component. I think, Mike, when you and I had a chance to talk recently, we talked about mental health and well-being being broad because it really is everything touches your mental health, your relationships,
and vice versa.
Yeah.
And between the two, which is reflective throughout the entire issue.
Absolutely. And so, when I came to Wellbeing Trust in sort of the beginning of the pandemic in May of 2020, I knew that there were needs. I had experiences in every setting I had ever been in that really underscored that there are underlying things here that we need to address to really move people from a place of need to flourishing. And so at Wellbeing Trust, that's kind of what we're focused on doing. And I'm so excited to be part of this panel today and hear from others to talk about, what some of the solutions may be as we move forward to address these needs together, because we have some ideas and we certainly work with a variety of partners to address the needs that we see. And a lot of the work that I do now is kind of focused on policy. But I think, if we've learned anything through the pandemic, it's that a system that was struggling prior to COVID has really been exacerbated, and there's more need and more demand, and we really need to find innovative ways to.
So if I had to ask you in just a few sentences to try to give me a shot of our audience, like what they should be keeping in mind as they hear this conversation, like something that would make them sit upright, whether it's statistics about mental wellness, whether it's issues about like post-crisis care or preventative care, like what do you want them to keep in mind?
Yeah, I mean, I could sit and I could reel off the statistics that we have around folks, having barriers to access to care. We could talk about the stigma that people feel in even engaging in a process of care. We could talk about the deficiencies, but I think what we want to focus on at Wellbeing Trust is that the opportunities that we have in front of us right now have not existed in a way that they've needed to, but haven't in many, many years. And I think, COVID has been awful for everyone. Yep. But it also has underscored this need and almost normalized, saying, I need help. I'm struggling. I can't do this by myself. I need to talk to someone. I need a different way of addressing my anxiety, my stress. And so I think, people are taking notice of that, and whether that's through funding at the federal level for certain programs, or, just, within our communities.
Sure. So that's great. That's a wonderful way of looking at it. Let's not worry about we could call out all of the problems, which we will, but let's also try to focus on the fact that we want to provide some solutions. And so I'm going to put that to our panel in a little bit as we bring them on, that let's try to focus not on creating these concrete priorities, but focusing on what types of solutions, given our opportunity set at this time. I'm going to ask Karen Zuckerberg to join us on stage. And while she does, maybe if you could give us one last parting shot on what your biggest, if you had a favorite solution, what would it be?
Oh, wow.
Like a wish list, a wish item.
Yeah, a wish list.
Says, this is a product that I can give you, Laura. Like, what is it you would want?
Oh, Mike, that's like asking somebody to say what their favorite song is.
You pick your favorite child. That's no big problem.
I only have one, so she's my favorite.
Oh, so that's easy for you. So perfect. Okay, great.
But no, I mean, I would say right now, one of the things that we really need to do, and I mean, for me, being in public health prevention and sort of the upstream solutions are really important to minimizing the more intensive need we see as people kind of move through that continuum. But I mean, for me, I think because we've identified that there is so much need right now, and we have a real opportunity in 2020, Congress authorized a 3-digit crisis number 988, and it will roll out in July of 2022, which is almost here. And yet there has been very little guidance or planning around implementing services at the local level to address the needs
So your biggest request would be, how do we tie together a high quality top-level mandate with actual operational delivery of that solution?
Yeah, getting those services embedded in communities across the nation, connect things.
That's a worthy request. We'll see if innovation can help with that aspect. Karen, thank you so much for joining us. I'm going to move to the side here and allow you to step in the lead. But so Karen and I have had conversations on this topic a number of times. She actually wanted me to give her a set of questions on these speakers in order to guide them. I'm like, no, Karen, that's not the way this is. This is open-ended. This is scary. This is see your pants flying here. We want to know your opinions on this topic as much as anybody else. So Karen, if you had a priority set, thinking about what Laura's just discussed and what her priorities are and what they're working on, I assume that you approve of many of them, but that's because mental health is such a wide area that you can have lots of favorites. What would you want everybody to be focusing on?
Well, absolutely. I think Laura brought up so many wonderful points. First of all, that mental health it starts in the family and it affects the entire family unit. If you have children with disabilities or autism, people who have suicidal ideation, or people who have substance abuse, this is going to affect the entire family. And there has been such a stigma attached to mental health and to seeking services that I think that trying to bring, community and telehealth to more people so that there can be more discussion and awareness that it's an ongoing problem for many people, that people aren't alone. COVID made many people feel that they were isolated and brought up a lot of anxiety and further increased depression. And having community is really important. And I know that, as you said, Laura, that they're implementing crisis coding so that telehealth can be implemented and used more. But there are also concerns on the parts of physicians that they will get reimbursed less. So this is something that I think needs to be addressed, that we're going to be able to address the needs of the people without the physicians having to worry about whether or not they're going to be reimbursed and how that's going to come about.
Excellent. So like if you had I'm going to ask you for the wish list item also, and then I'm going to step aside and bring the rest of our panel speakers on, and you can speak with them and everybody can start thinking about this together. But if you had a wish list item, Jeannie comes and gives you the item. What is it? What's one-off solution would you wish for right now? Your favorite child, so to speak.
If my wish list solution would be decreasing the feeling of isolation that people have in terms of seeking mental health care. Excellent wish. All right, with that, we've got Unity Stokes here and also Rich Melcombe. So Unity is the founder of Startup Health. These guys have done an amazing work, and they're currently holding the world's largest portfolio of healthcare innovation companies. We've been honored to partner with them both via the Alpha Partnership and the Impact Partnership, and I've enjoyed many of our conversations together on these topics. They are on a lifelong mission to improve the health and well-being of everyone in the world. Well, that's not a small goal there, is it? Just, are you sure you're shooting high enough? You're trying to improve the well-being of everybody? All right. Well, what?
We'll get into that.
Right? Excellent. And then Rich Melcombe. Now, Rich is a character. I love this guy. He is a TV and movie producer, and he's worked on television commercials, a number of other things. But what he's done most recently, which is really cool, is he's been partnering up with gaming companies to integrate into the Gamers Network, these electronically connected gamer networks. And I think what's most revolutionary is their attempt to create a social network, a microstructured social network with peer-to-peer support and other mental care services via their Vent program. With that, I hand off to you guys, and I'm going to just give you, like in Coffee Talk on the old Saturday Night Lives, topic for discussion. You can open with what your biggest priorities are, because remember, the first part of this session, we're trying to create concrete priorities. What would you focus on most first off? I'm going to ask you, Unity, first, since you have the ability to put dollars to work.
All right. Well, it's wonderful to be here. Thank you, Unity Stokes Startup Health. I believe we need to be thinking about this at scale for the world. So what I mean by that is a health moonshot for mental health and well-being. We need to inspire a generation of thousands of innovators, thousands of entrepreneurs, and thousands of investors around the world to be focusing on such a diverse range of ideas and solutions and innovations. So I don't think there's any one thing specifically. I think a whole generation, a whole ecosystem approach, and globally. I think there's so much need around the world, region by region, that we need to be focused on at scale. So more entrepreneur and innovation and more capital to support them.
I absolutely agree. And as you know, VC funding for mental health was $14.7 billion in all of 2020. And they have given just that much money in the first half of 2021. Rich, what do you see as the overarching issue for you?
Well, first off, let me explain what Vent is. Vent is a vertical, if Richie knows, which is a social network for gamers. And we did an alpha test in Los Angeles last summer, and Vent was outrageously successful. And what it is we just listened to people, and they came to speak their truth. And so what VET is community-driven mental health solutions. And that's what worked for us. And going into our test, the research showed about 82% of all gamers were unhappy. During our test, we couldn't find a happy person. What we discovered is America's in a mental health crisis.
Mm-hmm. Were there things that you were finding they were particularly unhappy about?
Absolutely. Gaming is huge. I love gaming. And Richie knows is a place you go when you're not playing a game to connect locally. Mm-hmm. The idea of Richie knows is in every market, every designated market area in the US, at least the top 30, there'll be a Richie knows and there'll be an event. Because I believe mental health is also local. And the idea that you can connect with like-minded people locally allowed people to, again, share their truth in a way I've never seen before. In television, I had a marketing company and my skill was emotional engagement. So we saw things that many of us on our team had never seen. And that's, people just, they don't want to be in virtual worlds all the time. They want to be in a real world and connect. And I can go on, but.
Well, that is definitely one of the issues that COVID has brought forth is the increasing feeling of isolation that people have had. And just the loss of camaraderie at work and getting together with people. So how do you see, do you see in terms of community incorporating groups, or do you see this more as an individual process?
Well, during our test, we produced about, we did close to 12 hours worth of programming. And we tested, our whole alpha test was focus group. It was live, 720 hours of live testing. And we did support groups, mental health journeys, relationships and love, and what we called overheards, just people discussing a mental health issue. And Karen, what we discovered was no matter what we branded, it was when people came in to watch the show on whatever, they came in via Richie Knows or they came in via YouTube or Twitch, it turned out to be whatever was on their mind and what was coming from their heart and what was troubling them. And, what we discovered was, people started off, with a brave face, but in every show we had, there were tears shed. And I do believe one of the greatest values was the idea of being in a community that they were passionate about with gaming. So there was an element of trust. Mm-hmm. And what we had was when people explained what was going on in their life, it was the community that acted. And then we had a mental health expert standing by. We partnered with NAMI nationally and NAMI Westside Los Angeles. So we had experts available. And so what distinguishes us from almost any other platform was the person sharing their story with other gamers or like-minded people and then having an expert stand by to answer questions only if asked. And what was interesting, we flipped it. As opposed to an expert coming on and telling people what was wrong, there was zero judgment, and it was beautiful.
Laura, do you feel that in terms of your experience, that the same aspects of community have you have noticed that?
Rich, thank you for describing the work that you're doing, because I think it's so interesting and important. And I'll say, from our perspective, and a lot of the work that we do is really about empowering networks and support where people are, wherever that is. And I think, we've talked about the role of technology and some of the concerns with technology, but I think the truth is, we need to make mental health and talking about mental health and empowering people with the skills that they need to help themselves and help others navigate mental health needs. We need to make those accessible wherever people are. And so one of the things that Wellbeing Trust is really leaning in on right now, when we're working with a team out of Harvard, is this idea of community initiated care. Mm-hmm. And I think, that can be a physical community, but it can also be an online community. I mean, I think we have definitely run into certain populations who, may live in a place where there aren't people like them, and they really gravitate towards some of these other platforms to find their community. But the idea behind it is that while it's wonderful that you have a mental health expert there to respond to need, what we want to do is empower everybody that's in that room to understand, to recognize that there's a need, and to be able to provide support in the moment to a friend, to a loved one, to themselves. And so it's really this idea about task shifting and unity, going back to what you were saying about sort of this global focus. I think we've seen this idea of empowering community members in other countries because they don't have the same medical resources that we have here. And how can we find a way to really bring that into the US and support people, wherever they are with that need, whether that's in a community setting, at home, or online?
I agree with you completely. What are your thoughts on this unity?
Well, I think, given we're talking about a universal issue to all humans, one of the interesting things that I think is happening as we look around the world is the solutions that are being created. So if you look at just a country like India as one example, well over 1 billion people, and there's like 1,000 or 2,000 psychiatrists that focus on mental health for 1.4 billion people. So what's emerging are new approaches that I think are just at the very nascent stages, but I think there's a big opportunity to be thinking and looking at different regions around the world, not just here in Silicon Valley. I'm in Berkeley, but all throughout the United States, but all throughout the world. And I think to be thinking about the possibilities for solutions in a much more diverse way than we've been thinking about mental health. So one quick example, we have about 33 companies that we've invested in. I hope one day that's 30,000. One company's focused on people of color, a company called Hurdle, emerging company called Genève, focusing on women going through menopause, a company called In Recovery, focusing on people with addiction issues. I think each of these are completely different needs. And so if we can inspire a generation of thousands of innovators and solutions that we can back as a world community, I think we can make more progress.
I think you bring up a lot of interesting points. First of all, I agree with you that we can learn a lot from other countries, emerging countries. We have an enormous number of provider shortage issue in many areas of this country, specifically in rural America. There are very few psychiatrists to render care. And so we are faced with telemedicine as the only way that people are having access to any kind of care. So I think, and also there are a lot of startups now that are focusing on communities, bringing people together in group settings. That's been common in weight loss in the past. But I like the fact that you're bringing up many other aspects that this can be used. Rich, how does this go back into what you were saying in your own community?
We were having echo.
Oh, I'm sorry. I think I was having echo. The question is, we were discussing how communities and groups were, in terms of eating disorders and substance abuse, have been very prevalent in the past. And what Unity is talking about is increasing community in many other different aspects of mental health care. And I was wondering how you saw that pertaining to your particular industry and what you're seeing in gaming.
Well, no, absolutely. Unity, what you mentioned, imagine on a micro level that we're able to connect people to whatever is troubling them. It might be as simple as you having a bad day to an eating disorder or depression or anxiety or whatever the issue might be. We had the ability, when they came to Richie Knows, a combination of NAMI and our own team. We had about 26 people working with us on our team. You could go in and check any issue and get information. And we rewrote some of it for younger people. If you read a lot of the information, it's tied to older people, and it wasn't tied to younger people. But then in our support groups and our video, our live shows, people literally connected with each other and would have private conversations. And what our whole goal was leading with heart and empathy. And when somebody has a problem and somebody else understands it, there's a natural connection and more of a validation. And so Karen, to be really specific, we have the opportunity to do every kind of nuance of mental health because, as with the digital platforms, it's unlimited of what we can do within the community.
So it sounds like moving forward in terms of a possible solution, or it might be increasing community to increase awareness and to increase access. So Laura, how do you, everyone's shaking their head, and I'd like to know what your thoughts are on how you think that we could move in that direction. Laura, would you like to start?
Yeah, sure. I think for us, we are really investing in this idea of task shifting and thinking about how we can leverage resources within these communities. That includes peers. Sometimes we have great networks of community health workers at some places, but really even going a layer deeper into our general population and working with communities to identify what their unique needs are, because we know that's going to vary, and providing them with easy ways to learn, act, and organize around supporting mental health need.
So this is great, guys. This is really good. I think we've got three very solid points, and Karen, you very well, you elucidated them pretty well already. But essentially, rather than focusing on the indications or specific problems, let's deal with how do we improve the community in terms of peer-to-peer support, or lessen feelings of loneliness and feelings of increased interaction. How do we increase access? And then how do we increase operational support so that fewer therapists or fewer licensed individuals can service a larger population, which feeds back into a lot of different things. I'm going to suggest those as being priority sets, and I'm going to throw it back to you for the last 5 minutes here in terms of adding refining points to that, in terms of how would we define that to solution providers?
Yes, I'd like to give each of you an opportunity to address that. So why don't we start with Unity? Would you like to start with how you feel that these major issues should be approached?
Yeah, I would say the first potential solution to these priorities, I think, is, as we use words like innovation, we we should think more broadly beyond just technology innovation. There's business model innovation. There's design innovation. There's innovation by region, by different types of people. So I think we should be very thoughtful and hopefully create awareness for the innovators out there, that there's all types of innovation in this area that we could and should be backing. The second, in a very practical way, I would say there's a new wave of innovators creating things today. This is very good news. And I think we could all, in different ways, support these people, these teams, these companies, whether it's through partnership or investment or just sharing their ideas with the world. There's a new generation emerging, and in very practical terms, if everyone just finds one of these innovators and supports them in some way, I think we can start to speed progress up.
I think that's an excellent point. One of the challenges is how we introduce and we make these innovators, people aware that these innovators are out there and that they have these wonderful ideas. Do you are you helping to do that?
Yeah, we're investing every quarter in new companies focusing in mental health. So we're focused very early stage. We do that. Anyone could go to healthmoonshots.com and see how we do that. We love to welcome everyone into our mission. But I think that you hit the nail on the head. We've got to open up and create understanding and awareness and connect the world with these people in very easy, accessible ways. And I think that's starting to happen thanks to technology and thanks to platforms and thanks to new ways to create access.
Yes, certainly technology has opened up a lot of opportunity for people in all areas. Laura, let me have your some of your concluding thoughts here.
Yeah, I love what you said, Unity, and I think it's so important. You know, one of the things that we are really focused on is making sure that we're listening to the people who have needs. And so, you know, when me at 44, after 20 years in public health, I can't sit in a room and decide what youth need. They need to be at the table. They are the ones who are able to communicate about those needs and are oftentimes the ones who have the solutions that you're speaking of. And so really making sure that we're looking across different populations. And, you know, I mean, for us, this applies in everything, the data that we're collecting, the investments that we make, but really making sure that the solutions that we design are made to meet the needs of the people who need them. And so making sure to incorporate those voices at every stage, I think, is something that is really critical.
Absolutely, Laura. I think what you're saying is so spot on and so very important. And Rich, how do you see, what would you like to say in conclusion in terms of your positive attitude out there?
Well, I got to tell you, it was so special doing that. For us, it's destigmatizing mental health and giving people a voice and validating and communicating and listening in a way that they want to. We had no preconceived notions going in. And when we ended our test, everybody was there. And, you know, in a really strange way, everybody's a mental health expert if they just listen, and then you could funnel people to the right place to go to get additional help. Our vent is a place to go, one, to acknowledge you have something that you feel different about, and then depending upon what your needs are, to go through NAMI locally or different local providers. But for us, it's about destigmatizing and reimagining mental health.
Absolutely. Destigmatizing mental health, gaining more access, increasing innovation. All of these are so important. I want to thank everyone, Unity, Laura, Rich. You've been a wonderful panel. I think you presented lots of challenges and lots of excellent ideas as far as where we can go from here.
And I want to thank you, Dr. Zuckerberg, because you were an excellent host here. This was fantastic. Great panel, everyone, and thank you all for joining us today. When we are done with the conference, we will be writing up all of the conclusions from our panels and proposing them as forward-looking action points in order to address specific issues, in order to invite RFPs from companies and other solution providers in order to pinpoint those exact action points which our panelists so wisely brought forward. So our next panel coming up is healthcare access or healthcare equity, depending on how you want to approach it. But recent studies have shown that despite the improvements in the overall health of the country, racial and ethnic minorities experience a much lower quality of healthcare. No surprise there. They are less likely to receive routine medical care and face higher rates of morbidity and mortality than non-minorities. It's also true that depending on the community in which they live, patients may experience great differentials in the quality of care provided. We believe we can use innovation to improve delivery and access to healthcare so that it does not discriminate based on race, geographic, or socioeconomic issues. Now, this is a very, very lofty goal, but first we have to appreciate the fact that it is in fact a problem. I'm joined today as our lead speaker by Dr. Juliet Nevins. Juliet is a fantastic contributor. She's actually the Clinical Solutions Director at Aetna, part of CVS Health, but she's also a practicing OBGYN and also the founder CEO of Below the Belly Button, providing consumer-targeted health education via digital and in-person platforms. I imagine with the name Below the Belly Button, this is specifically targeting maternal health and labor issues?
Correct. Yes, it's basically Well Woman's website, if you will.
Got it. And can you tell me a little bit, Julia, why did you focus on this aspect, other than the fact that you're OBGYN? What are the main concerns that you have here?
Well, a lot of the disparities affect women. We've heard in the last year about the increased morbidity and mortality in terms of maternal care. And if you look at other diagnoses, there too, you'll find that a lot of the disparities affect women across the board. And certainly if you get granular, you'll find that those disparities target women of color. My interest has always been aligned with my clinical career as an OBGYN, in that my interest is in terms of population health, is getting to the policies and the programs that are important for this cohort.
Now, I suppose the first most important thing is that we acknowledge that it is a problem. So thank goodness we're starting to actually bring this up as a major issue. Now, I am aware that the Black Women's Congressional Caucus came up with something called the Black Momnibus. Could you tell us a little bit about that and what the purpose of that was?
So it's a compilation, if you will, of different programs and policies that the group who came up with the Momnibus hope to enact. Technology is one part of it. Ways to address social determinants of health is another part of it. So it's a multi-pronged approach in terms of putting laws and mandates in place that will trickle down and target this problem in its totality.
Got it. So outside of maternal health, which obviously is your focus specifically, I imagine you are dealing with a lot of other aspects of this in terms of drug delivery, in terms of healthcare delivery, in terms of telemedicine access. If you had something that you would like to educate our audience on that they may not know about in terms of negative impact of healthcare delivery, not negative impact of delivery, lack of delivery, let's say, what would that be? Like, give us a nugget of wisdom that we can start with.
Well, I'm glad I joined early because I was able to hear the conversation from the prior panel. And all of this does tie into the mental health that affects this group. And it lends to a circuitous sort of pathway, right? When people don't feel involved, when they don't feel heard or seen, that in of self is often unquantifiable. It's untangible, but that then too leads to worse outcomes for certain cohorts. So it's a nuanced look at this. There's certainly a lot of pieces that we can look at and focus on, But I think that's one avenue that we should definitely pay attention to. And I wanted to share that with the audience today.
I think that's so excellently put. So many of the issues that we brought up, when we thought of these 5 channels originally 4 months ago, before we started doing the research into them, they felt like 5 separate channels. Now we realize it's one giant channel that's all just with different focuses. Like, in many ways, we need to go back and start thinking about how do we create better interaction between all of these different pathways themselves. So to that point, you mentioned something about not being seen, not being heard. In my mind, that also leads into this aspect of lack of trust of the system itself, that they don't trust that the system's hearing them. And it's kind of been proven out in many ways. Is that right?
Well, that is absolutely correct. I look at the issue around access in sort of a hierarchical function, right? There are the larger structural issues that then trickle down and lead to poor outcomes. Your zip code, where you live, and where you live determines variables that directly impact your health, food deserts, for example, safe places to get exercise, health literacy. So we can start there. Then based on that, if you have a complex diagnosis that requires an entity that's optimally resourced to take care of that, is anyone even referring you? Is anyone saying, you know what, you can't care, we can't optimally care for this problem here, go to entity X? Do you have transportation to get there? Do you really have the health literacy to understand the concept of a higher level of care? And that's where I come in, because I am very much about health literacy and making sure that patients and people in the community understand what diabetes is. It's not just sugar. What does it do? Do you know that it's the leading cause of blindness for adults in America? So these are pearls, really important nuggets of information that if the patients and if the population who suffer for them most really understood, I think that would lend to an impetus for them to act and to be more involved.
So in many ways, we have another feedback loop here, right? Is that many of these underserved communities don't trust the system to take care of them, don't trust them to see or hear them, and therefore they're not seeking education or support. And so we need to circumvent that. We need to short circuit it.
Or they don't believe the information that's being given.
There you go. So we need to start somewhere. Now, the good news is we can start with education. Would you propose this then as your first and foremost aspect of dealing with the healthcare access, or is there other issues that you would like us to be aware about also?
Well, in terms of my niche, that's my focus. And on your last panel, a member of one of your panelists said it, really, she used the term group care, if you will. Mm-hmm. And I think that's certainly another important component, educating the population so that they can really be involved in shared decision making, so that they can be stakeholders in what's happening around them. And with information, you can better vet what's for you, what's not for you. And if you understand at baseline, then you can have a conversation with your provider where you're going in with a different level of trust.
Excellent. Thank you so much. If there was one other thing that we would address, now, obviously, when we talk about equity and access, many parts of that are financially based. Mm-hmm. But we've addressed now at least one item, really two, both education and I would say community support or community networking, your local support group plus the community support group. Is there another way that doesn't involve like direct taxation kind of thing? Is there something where innovation in your mind would be the most effective means of support, whether it be telemedicine, whether it be behavioral modification in terms of health monitoring, like with our smartwatches, or anything else like that? What's your wish item if you saw the previous panel?
Well, I will tell you, technology is very important. And I think as we emerge out of this pandemic, what we have seen is that patients are willing to access healthcare virtually, if you will. And we can tap into that. we can use that to shorten wait times for either mental health providers. We can, if you are a diabetic and you have been taught, or you have an app on your phone such that you are monitoring your sugars, virtually you can convey that information to your provider and get care. That provider can, for example, adjust your insulin at an earlier point in your disease, as opposed to waiting until you come in 6 months later. So that's a concrete example of how technology at the point of the individual can be helpful. In terms of our infrastructure, I will tell you, my one pet peeve when I was a resident is the electronic medical records. In that everybody has one, but nothing is connected, right?
Yeah.
There's no way you can get objective data about what's going on with the patients if they have been seen or if they received care in a different facility. So
well, I think we're gonna have to be bringing people on to, like, as guests of other parts of our panel. In fact, bridging the digital divide is a specific topic around medical records and integrating these things. So we're definitely going to have you there.
Wonderful.
Well, you can chime in from the audience, and maybe we'll bring you on if we have the time. But there was one thing I wanted to bring up before I hand it off to Katie, Dr. Richardson, and that's that: does a virtual healthcare system suffer or solve issues of trust? Like, meaning having it virtual, there's got to be a trust component. Is having it at arm's distance in terms of relying on this network, is that like better or worse in terms of building trust with the patient?
It cannot replace the face-to-face interaction. We should think of it as an adjunct, not a replacement. So, and I like to use concrete examples so that we're not talking, about intangible things or intangible situations. Once you have established a relationship with your physician, you can then employ virtual access or virtual medicine as a means of continuing care or continuing that relationship, or as a way of reducing the interval between visits. So that's one thing. It's an adjunct. It's not a replacement. And the other thing I always stress when I talk about this, it works alongside the in-person visitations, in that the providers have an opportunity to triage, right? Decide what patient is amenable to the virtual access, what level of disease burden, for example, is amenable to the virtual access. It's a tool. If we start thinking about it as a replacement, I think we're going to go down the wrong line. But if you have an established patient, my doctor told me to come back in 6 months. Okay, I'm not doing that. So let's set up a virtual visit so I can talk to you and tell you about what's going on with me in the meantime.
I couldn't imagine a better transition for me to bring in my pitch club partner here, Dr. Katie Richardson. She and I have had many conversations on topics of healthcare equity, and one of the things that comes up is the concept of being able to triage to provide better access. So I'm going to hand off and start there, and then maybe ask you to talk a little bit about some of the other observations that Dr. Nevins has made thus far.
Absolutely. Thanks, Mike. And thanks, Juliet. Some great points, I think, to start this conversation out. But I 100% agree, right? Healthcare relationships between provider and patient, no matter at what level, are built on trust. So being able to develop that trust with your patient is important. A lot of times that is a face-to-face visit to begin with. But we also know or have seen in cases, again, to tie it back to actually our previous conversation, our previous topic, the crisis text line that is out there, again, is a nationwide opportunity for folks, again, who are in mental health crisis. And what they have found is there are many patients that are much more willing to share because of the anonymity that comes along with that text conversation that's happening. So again, I think it's got to be a balance, and Juliet said that. And Mike, to your point, this idea that we do need to help patients understand. So where are they going to be best served? How do we help them triage from a perspective of, do they need to be in the emergency room? Does it need to be a face-to-face visit in the office, or could it be a virtual visit? Because I think there are many different ways to access care, and this idea that we need kind of navigation support for many patients, the way that I would talk about it. No matter whether we are talking about healthcare disparities or not, the healthcare system is hard to navigate. And so solutions in that space, I think, would be great. I want to set a little bit the stage for the remainder of this discussion just by putting out there what I think is a great definition of healthcare equity. So healthcare equity or health equity generally refers to individuals achieving their highest level of health through the elimination of disparities in health and health care. So again, this idea that health and healthcare are not necessarily the same thing, right? We are talking about two different things. And we know that there are factors both within the healthcare system and far beyond that. And Juliet, you tapped into many of those, I think. It is your zip code. It is your education level. It also is, are you employed? Do you have a roof over your head? Many of those things, in addition to another point you made, which I thought was awesome, this idea of social support systems and that social integration. We talk about food as medicine. So the other thing would be, food security or food insecurity. And then one of the other, I think baseline disparity really is access to the healthcare system. So this idea, again, that is one of those larger areas that we're talking about. And although we made great gains, I was just going to say quickly, in coverage for a lot of patients out there, we have seen in the past 4 years kind of a backslide in the amount of coverage and the folks that are covered out there. So those are all aspects that I hope we get to talk about with our panel. Go ahead, Mike.
Yeah, that's all right. I just wanted to bring in Yapala here. That's all right. I messed up your last name. I practiced your first name.
KP.
KP from here on out. Thank you. Take the pressure off.
Well done. Good.
Much appreciated. Kaapama I got. It was the last name that I hadn't practiced, so I apologize for that. But KP. So KP, he's currently the founder and CEO of InOn Health, and they're specifically looking at technological solutions to increase access to both education and other aspects. KP, maybe just tell us a brief bit about what the issues are, not that InOn Health is trying to solve, but why they need to be solved, and maybe the work that you're doing with the Commission for IT in the state of Colorado and the work you're doing with the state governance in terms of providing more access there. Yeah, there we have access and engagement issues. There you go. It's all about access, right?
Great. Indeed. Can you hear me well?
We can now, yes. Thank you.
Very good. Thanks so much for having me. And Dr. Nevins, you really kind of teed up some key issues, as well as Dr. Richardson. So I go by KP. I think, as we all know, the conversation about health equity is one that's oriented or anchored around values in our society, right? So really what we're getting at the heart of it is that there are avoidable disparities in our country based on systemic issues, race, gender, sexual orientation, all the things. And really what health equity is about, in my view, is reducing those disparities and setting the intention as a society that that's what we believe is the right thing to do. And if we all align that that's the right thing to do, then we're going to take the action to do that, right? So for me, just like as a principle, like that's the why, right? In terms of what we do, and we are, my parents are both from Ghana, so my family are immigrants to the U.S. I'm a first-generation American. And the issues of healthcare access for BIPOC populations, and also globally, like my career has also done this work in African countries, is that, there are ways that we can reduce disparities. There are ways that if we're intentional, particularly around using digital innovation, that we can bridge the gap. But if we're not intentional, as has been brought up, digital innovations aren't equally accessible, right? So actually digital innovation can deepen disparities if we're not careful. But I think that, here in Colorado, I'm based in Denver. I'm the incoming chair of the Colorado eHealth Commission, which governs all health IT for our state. And the specific mandate and part of why I've been brought into this role is to really focus on how we think about digital inclusion and operationalizing digital health equity. So not just setting the principles, but ensuring that what we do and how we use technology bridges the gap. So I'm really passionate about the topic, really curious to hear from my colleagues here on the panel today and add whatever insights I can.
Well, let me introduce Daryl Chapman now. Sorry, Katie. I just want to bring in Daryl.
Go for it.
His intro, and then you guys can take it from there. So Daryl, actually, I met him just a couple of days ago, or a week ago now, I suppose, via some connections we have here from Dr. Jeff Cohen, who will be the lead speaker on one of our later panels. Daryl's got a really remarkable background, including his current work right now, working to improve pharmaceutical distribution in African countries via a IT network and decrease the amount of counterfeiting going on there. But also Daryl has some unique insights on what he's learned from developing that product and how it can be brought back to the US in terms of improving access and creating a more equitable playing field. Daryl, could you talk a little bit about that?
Absolutely. So my name is Darrell Chapman, and going on that, and KP hit it perfectly on the nail, is being intentional. And both of my experience over doing work in Ghana and in Nigeria, you do have to be very intentional with what initiative you are putting in place and understanding the ecosystem and the environment that you're working on, because a lot of the issues that they're dealing with and a lot of barriers that they're dealing with on a day-to-day basis is seen as almost a luxury when you come back over to the United States, but they are still prevalent throughout the United States in what we call these healthcare deserts. These healthcare deserts, which are in the low socioeconomic communities within America. So it's one of those things where you do go overseas, you see these issues, and that may be a norm for them. And as us as Americans who are tailored and trained to think as though that's something that just happens with a third world country, but that's actually false. It's something that happens, in our neighborhoods and in our backyards. I know me specifically, I'm from Flint, Michigan, and I hit it day to day, every single day. I have the disparity of not having access to adequate care and dealing with issues as far as health access.
Great. And Mike, do you also want to introduce Mark J. we have up here too?
Certainly is. Hi, Mark. How are you? Thanks for joining us today. Mark is the Senior Fellow at the Center for Healthcare Affordability out of the Sagamore Institute. And these guys are really doing an amazing work in terms of improving, well, let's put it this way. They're trying to curate strategic solutions to fix America's broken healthcare system, which basically makes him a poster child for exactly the Impact Conference and what we're trying to do here together. So, Mark, based on what you've heard so far from these extremely wise individuals, I would say, what do you think so far in terms of what work you're doing specifically to try to address some of their issues?
Yes. Thank you for having me. And, Dr. Nevins made an interesting point, and several others have too, there's a lack of trust in the healthcare system. And so at the Sagamore Institute, we're focusing on the importance of transparency, and price transparency being one of those. Now, price transparency will not fix every healthcare, but you cannot fix healthcare without price transparency. So this is all about holding the healthcare providers really accountable to things that are already in place, to being transparent on pricing. So if you have people that are already leery of the healthcare system and they're going in, if they have the access to healthcare, then they're going in blindly, not knowing even what this appointment or this particular service is going to cost me. So that is our focus of really just educating and really advocating. And in certain situations, you need to have legislation to really kind of push those providers to step up to the plate and provide transparency.
I agree. Mark, thank you so much for bringing up, I think, cost specifically, but price transparency as well. Medical bills are one of the largest areas of debt for Americans, essentially. And so I think that is a critical piece, a critical economic piece that plays a role here. I'm going to just ask a question. I'd love to hear from everyone. What issues do you think are at the root. If you had to pick the top 1 to 3 issues really that are at the root and creating these disparities, what would you say those are? KP, I'll start with you.
Well, if we don't all agree on what health equity is, then we have a problem, right? So in our country today, there is not consensus on what health equity is. And to be frank, if we're in a society now in our country where even talking about the topic of racism or accepting that racism exists in our society is a conversation, like we're debating that. Like if there's a debate about that and we're not aligned on it, on kind of talking about that and understanding what's going on in our society, how can we talk effectively about what racial disparities in health are and what the drivers of them are, right? So I think that at the root of this, there's a much deeper set of issues that are going on around definitions. So for example, here in the state of Colorado, I'm a co-chair of the Health Information Exchange Working Group. And that working group is looking right now at the issue of standardizing how we think about race, ethnicity, language, gender, sexual orientation from a data perspective. So we can all align around what we're measuring and how we're thinking about what disparities exist. So that's like your baseline. But then as for the why questions, so even if we cross that bridge and we're able to measure, and then now we have to ask ourselves why these disparities exist. If we don't start to get into these root causes and deeper societal issues and align, it becomes very hard to design impactful interventions, right? So I think, I just want to be forthright and say that that's what I see as are the root issues right now. Because what you find is, in many ways, if we just implement, and I'd be curious to hear from Dr. Nevins and others, but in many ways, if we just implement the best practice in clinical medicine, and there is not implicit bias or systemic racism, people's health outcomes are good, right? So then it's like the science is there to say if we implement these things well, people can be healthy, right? So then you have to ask yourself, why aren't these best practice standards getting implemented in a standardized way for everybody, right? And to me, that's the heart of the matter.
So what I hear you saying, I'm just going to paraphrase, is that racism and discrimination play a role. And, I definitely think, implicit bias is an issue. I worked for a long time for an integrated healthcare delivery system, and we educated a lot of providers on even what is implicit bias and, how do we identify it and what does it mean in healthcare delivery? So I agree with you. I think it is, one, we need to be in agreement that it's an issue. And two, we need to then uncover where those biases are. And I think we know quite a few of them, and then be able to, go after them and understand them. And again, implement, what I would call evidence-based medicine across the board. The other point that you made, I think, was really great around race data, essentially, even collection of data. So at same said integrated healthcare system, large integrated healthcare system, that was one of the biggest things that we were working on, is even having that data in the electronic health record across the board. So this idea that, we're even asking those questions because we should be, is an issue. And then making sure that that data is entered and we're able to access it in a meaningful way, I think is also very important. And when I look at, again, a system that was focusing on it and still how poor the numbers were, we have a long way to go. I'm with you. Juliet, I'd love to hear from you on, what do you think the issues are that are most responsible for creating the disparities in healthcare equity and access?
Well, I'm going to delineate 3. A, it's an ism. Racism, right? Sexism. I mean, if I go into the emergency room with chest pain, I'm going to wait an hour longer than the man for someone to take me seriously, right? And then because I'm Black and a woman, then I'm really in trouble. So we need to really be honest that it is a problem. Secondly, and KP, I have to sort of, snatch up one of your statements in that I'm a very proponent of electronic medical records or systems that facilitate care that is agnostic, right, to race, gender, sexual orientation, blah, 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 right? And that way you eliminate individual bias if you have to do X before you can move on to Y. The third thing is cost. It's, when we think of cost, and Mark, in addition to transparency, I believe there's a notion that I don't think people understand that it costs the national economy when there are disparities, right? It's expensive. And from the payer side of it, I can tell you, I can see how much money goes when things go awry and you have the person coming in with uncontrolled diabetes, right? That only, trickles down. I mean, somebody is going to pay for that. And it's us, meaning that all Americans, irrespective of your line of business. So I think people need to understand that it's not those people over there. It affects the pockets, if you will, of everyone who lives here. So those are my 3 points.
I love it. Darrell, I'm going to call on you next. I'd love to hear from you. Same question.
Absolutely. And I think it comes down to two things, which is one is a lack of accountability and lack of perspective. We're talking about health disparities here. As far as lack of accountability, when you have these type of things, you have a health disparity, those begin to snowball. And once those snowball because they're not being addressed, then you have the situations that we're in now. For instance, right now, Dr. Nevins brought up with being a woman and being in a hospital. You talk about patients who are in postpartum. You have a hospital who's constantly having issues, who are mistreating patients who are going through postpartum depression, and this is not being addressed. It begins to snowball and happens over and over and over again. And if the hospital does not understand that this is an issue, it's never going to be addressed. And that's a lack of accountability, and these disparities continue on. And as far as disparities, this is something that continuously, as far as perspective, this is something that continuously happens as well. You have people in these positions within healthcare who don't have a clear understanding of what the patient is going through on a day-to-day basis and their ability to gain access to certain care. That's a huge issue. You have a physician who's just saying, hey, just go to your PCP. But there's a lot of different factors that go into that. There's transportation. And then you have someone who has a chronic disease, they're having food insecurity. All of this builds on. It starts off, then now they need dental care. After dental care, now they start to get continuing issues. And now, as you know it, they're stuck in this cycle, and it starts to go down their family tree as well, as far as how they're viewing medicine, how they're treating medicine, and how their perspective of the illness within the family, going from lineage to lineage, as far as how they can address these things. And it starts to almost brainwash the patient almost outside of that healthcare system, as far as how they can treat these issues. And you see it all the time with mental health. Mental health is almost non-existent in the Black community because that's something that we never had the initial access to and understanding of how to treat, because these health disparities have been persistent in our communities.
Great points. A couple of things. And again, just a tidbit of potentially where, and Juliet, I appreciate you talked about as well, like, where does innovation have a place here? I actually had the opportunity at an event here in Denver to put on some virtual reality goggles, and I had a hearing problem, and with these goggles I had macular degeneration, which essentially you lose sight from the center out, right, as you age. And I went through, as a patient, a visit with my healthcare provider in that situation, both this loss of hearing and loss of sight. And wow, like the empathy that I felt, and it gave a new perspective for me, just understanding that condition so much more. So I love your point, Darrell, about how do we get healthcare providers to understand some of those things, and maybe technology can play a role there. Mark, how about you talk about, so outside of cost transparency, talk a little bit more about what other issues you think are most responsible for these disparities.
Well, I think, sadly, we have a multi-tier system in terms of quality of care. So if you are in a Medicaid scenario, you do not have access to the same type of care as you would maybe a larger network.
Mm-hmm.
And people may think, how dare you say such a thing? But it is a reality. If people are on Medicaid know that they have to go to the ER and that's how they're going to receive their treatment, well, then that just bogs down the ER. And if people aren't being seen because if there's some incentive to treat one patient over another, I don't know. But it's unfortunate that the healthcare system, I know it keeps coming back to that, but the cost of the healthcare system, again, as Dr. Nevins mentioned earlier, is it has this ripple effect. It affects the entire country. Maybe not one neighborhood versus another, but nationwide, if we don't have affordable healthcare, it's really a travesty. Everyone needs to be able to have access to it, and it comes down to a trust issue and transparency. Then we have a long way to go to build those bridges, I think.
Yes, and I agree completely. Sounds like I have a little bit of an echo right now, so I apologize for that. This is not a new issue, right? The idea that there are disparities in healthcare, but one of the things I'm hopeful for, COVID, a global pandemic, COVID has brought a few things to the forefront, and I am hopeful that. Unfortunately, disparities in healthcare happen to be one of them. We've all seen the data. We've all probably heard the news. But same thing with mental health, right? COVID has brought several things to the forefront, which hopefully we can spend a little more time putting focus on, because there has not been focus on them in the past. And Mike, it sounds like you're going to probably take us home here. And
I want to propose a framework for trying to pull together some of these threads. I mean, obviously, we weren't going to solve all of the world's problems in 30 minutes here, folks. We knew that from the outset. But there's some amazing points that have been made here. Like the first things that I wrote down were about trust, education, and technology as being solutions. But then we got into this idea of education, access, removing bias. All of these things start pulling together. Can we start and think about commonality issues? One of the problems we have when we say education, that's as nebulous as equity in the first place. Like, what kind of education? Are you talking about literally Sesame Street here? Or are we talking about much higher quality? Talking about interactive education? Talking about just teaching our providers to provide education at the point of care and accelerating that outcome. I'd like you guys to kind of like bandy about here a little bit more along the lines of give me focused potential solutions. And I know that's a little bit hard because it's such a large topic, but given the wide range that we covered, maybe our panelists' ideas on this and make my job a little easier for me.
So where to start with solutions? Mark, you can go first.
Well, you're right. Education is, a very broad sense, but I don't think it can be minimized, though. The importance of people knowing where to go or what is needed is critical. And so, I actually used to live in Denver, and I was with a healthcare startup company that focused just on that, was educating people to get better access to the healthcare. It was all through phone technology, and they had unlimited resources through all this education. So it's going to have to require baby steps. And I think for those people who have employers that are willing to invest in some of these companies that are trying to disrupt the healthcare system, they need to spend that extra dollar to say, hey, how can I get my employees better educated, and which will lead to better access. They'll know where they need to go and when they need to get the access for care.
Great. KP, where should we start with solutions?
Yeah, so I'm still kind of in the mindset of first aligning on measurement. What are we measuring? So, and again, it's a definitions issue. So if we talk about the isms, like what disparities are we measuring? So health equity is not just about racial disparities in health. It's about a wide range of issues. So if we can agree on what we're measuring and we can effectively measure disparities, then the next step is tying reducing disparities to value. And, my friend always says, follow the money. So if we can tie reducing disparities to value, you can watch the market move towards actually solving those problems. Because frankly, as has been said by my colleagues, a lot of the cost issue in our health system also is inside of these pockets of underserved, vulnerable BIPOC populations. Poor health outcomes, high costs, low quality of care. If we can align the incentives and the value to that, we can watch the market move. But that starts with aligning on what we're measuring.
Yeah, I love it. So are we measuring the right things? Can we agree on what we're going to measure? And then how do we align incentives to make sure that, again, we are reducing? We can incentivize providers, systems, hospitals to reduce those disparities. I love that idea. I'm just going to point out quickly, one of the physicians and our CAB members in the audience talked about the fact that there's very limited compensation for health education. So this idea that we're going to, again, we got to follow the dollars, to your point, KP. Like, if we're going to educate, we got to pay people to do it. Juliet, how about you? Where would you land on? Where do we start with solutions?
Well, if we stay within the education space, right, we have to educate patients. And I always like to use concrete examples because I think it helps to bring home my points. Diabetes. I've had so many patients walk into the office and say, oh, everybody in my family has diabetes, right? And that tells me that there is a lack of understanding about the cause of the disease and the severe sequela. Darrell, you talked about processes that get passed down from generation to generation. This is a place where you can innovate, right? There are lots of things that you can do on a phone, on the screen, to sort of interrupt that way of thinking within a family structure. So there's an example there. In terms of the provider side, the idiosyncrasies that individuals approach an individual can approach another individual with in terms of racism, I just learned that I am privileged, right? We talk about white privilege all the time, but I learned that there's English speaking privilege, right? There is a privilege of someone who is educated versus someone who's not. And all of these privileges separate you and create barriers. And I think, again, tools that allow people to empathize, because it teaches understanding, right, of not only but it demonstrates similarities between you and another human being. So in terms of education, I think that's a great place to insert technology in terms of changing how people think on both sides, the patient and the provider.
Yeah, I agree with you completely. One of the things that we tried to do in a role that I had on our diversity, equity, and inclusion team really was this idea of educating providers, because what we know is having a greater understanding of what our patients are going through, where they're coming from culturally, where they're coming from, related to a lot of those factors that you mentioned, Juliet, we're going to be able to deliver better care. And I would say on the whole, those are not things. I mean, you can agree or disagree with me, but those are not things they talk about a lot in medical school. So we got to start at the beginning, right? And then educate the masses of healthcare providers that are out there now as well. Darrell?
Katie, I just want to tag on something to your statements before you redirect. Another space is getting providers who are aligned with the language, ethnicity, race of the target group would be very helpful. It's difficult to teach about nutrition if you're talking to someone who speaks Creole and who's from Haiti, right? Even if you spoke French, it's that cultural divide is a challenge. So that's another layer in terms of what we can do around the space of education.
I agree completely. Thanks for adding that. Darrell, I'll let you wrap us up, because I know Mike's probably itching to move us on. But where would you start with solutions?
as far as solutioning, it's getting boots on the ground, getting the innovator in the situation, or bringing in a stakeholder who understands the situation firsthand. I'll never forget, I was hired to make modular beds for labor and delivery over in Ghana. I get over in the clinic, I walk into the maternity ward, and I'm seeing the patients, they're laying on the ground, but I see all the physicians with a vial of blood tipping it back and forth. And I asked, what are you doing? Why are you guys just tipping this blood? And they say, oh, we can't bring the patient to get a C-section unless we know about their blood coagulation levels. I'm like, what about the lab? The lab takes 48 hours.
Oh, wow.
So we have some of those situations that I wouldn't have known if I would have never taken that trip over to Ghana, having my feet on the ground and understanding the situation firsthand. That's going to be important. And that's how a lot of devices, softwares, and initiatives are off target, because they do not understand the situations from their own eyes and from their own situation.
I love that point. And it brings us back to AngelMD in my mind, right? It is bringing the innovators and the healthcare providers together really to develop the best outcomes for our patients. So Mike, I'll let you wrap us up, but thank you all for being here. I have loved this conversation, and I could really continue to talk to you all for another couple of hours. So we're going to have to get this together again.
There we go. I had to mute because I was creating echo, I think. Thanks so much, everybody. This has been fantastic. All of our speakers, Katie did an excellent job. What a great panel. I'm going to stay with a couple of items that I think I'm going to be proposing for our action items afterwards. They are definitely along the lines of follow-up is a great opportunity for both education and continuing care, as Dr. Macaluso mentioned in the comments as well, that it's often the effect after the case, after the disease, after the critical, that very often creates the outsized cost and stress on the system. It also, as Juliet mentioned, creates the kind of that generational cycle or the internal cycle of not staying on top of the disease, of not educating the support network of the disease. So I think follow-up is a big word to use. I think trust is a big word to use. This deals with both empathy. This also deals with alignment of outcomes in terms of, as you mentioned, language and other aspects of connection and things like that. So I think trust is something that I think we're going to be addressing. How do we build that trust out? Are there ways to improve the trust profile between patient and the system that will frankly allow greater access for education? And then finally, I thought a great point was made by KP on the data aspect, that if we create the right data profile and we collect enough of it, then perhaps we can create alignment in terms of outcomes, such that when we have innovators, as one of the commentators mentioned, that so much innovation is directed at the problems of the 1% because they pay for it, right? And so because they're the ones that are actually paying for it, they're the ones that are getting the healthcare for their specialty needs. Well, the reality is the 1% is paying for healthcare across the board, if you want to use that argument. If you want to talk about like who is paying the tax load of the healthcare system and of the Medicare, Medicaid system, it comes from the highest income providers. So let's give them all a positive study that shows that proper healthcare for everyone benefits everyone, and leaves that as a way to kind of pry open those wallets and make people a little bit more aware of the problems that exist across our society, not just for select few. Anyway, I think I'm going to go with those. And obviously all of these comments, like the white papers that we put out for each of these panels, will be open for commentary from everyone here and anyone that's registered for these conferences, because we want all of your inputs. Legitimately, we do want your input. This is not bullshit. Sorry, this is not BS. We want to hear what you have to say. So thank you so much, Katie. With that, I'm going to move on to our next panel, which is the innovation ecosystem. I had difficulty with this title because innovation ecosystem sounds like the ecosystem for innovation itself, and that's not what we meant at all. We meant much more the way the ecosystem of the entire community can potentially be assisted or feeds back with innovation too. So with that, we start off with this concept of that the health of a community and its socioeconomic aspect is directly tied with the health care of that community as well, and that they feed back and forth to one another. And that hopefully, just maybe, we can do something with innovation that'll reverse that spiral. So with that, I open with my lead speaker, Dr. Jeff Cohen. Dr. Cohen and I met via Joe Macaluso, who was commenting so well in the chat box. We do read those, folks, so feel free to go ahead and chime in there. We're watching you. And Dr. Cohen is doing some amazing work in the suburban hospital system of the Allegheny Health Network, where he was, the title is challenging, where he was doing something really remarkable, taking a mothball hospital facility and converting it into an innovation center, but also a community hub. Doctor, maybe you can just give us a brief background on why you came across this project and why you think it matters so much to the community that you're doing it in.
So good afternoon, Michael, and a shout out to my good friend Joe Macaluso. I'm a practicing urologist, and about 2015 or so, I took on the presidency of a quaternary hospital, about 550 beds. And I got to see things that I'd never seen before, called finances. And in the medical world, as a physician, I ran a multi-location practice with about 10 urologists. You see a very skewed sense of the world. When you're president of a hospital, and my budget was around $900 million, you start to see patterns. And the one thing that surgeons are very good at is recognizing patterns. We don't do well reading, but we do recognize patterns. And one of the patterns that I kept seeing was that every month, 4% of my population was taking up 15% of my resources. And when I went to see who they were, it was mostly Medicaid patients that lived immediately around the hospital. And we started looking into this problem and started some, processes to try and understand what's going on here. And this led us down a path where it changed a lot of my views. And I listened to the last discussion about the healthcare system and the inadequacies of it. I don't go down that path anymore. I go down a path that there's something about poverty that impairs the host's response to care. So what we were seeing was that in the Medicaid population, our length of stay was 50% higher for the same diseases. They had higher wound infections. The poor just did worse. And you were talking at the beginning of the session about healthcare inequities. The bottom 5% of the population in the United States has a median survival of 63 years. The top 5% is 78 years. The fundamental definition of health inequities are the processes that lead to that difference in survival. And as they pointed out, the wealth of a nation is based on the productivity of its citizenry. So why in God's name are we allowing people to die 15 years earlier? And is it related to something about the environment that's affecting the host? So this took me down a very different path, which was I accomplished what I set out to do at Allegheny. And they said, well, what are you going to do? And I said, well, I'm just going to go do what Macaluso would do and just go run my private company. And they said, well, do you have any interest in doing anything else? And I said, well, yeah. Pittsburgh went through this process of reconstructing itself after the death of steel. And one of the things early in my career I was stunned by is that what do you do with a 55-year-old steelworker? And the answer is not much. And on a productivity basis, there's not a lot for people at that point in their lives to do. So we started looking at the relationships of poverty and healthcare. And, we noticed that there were about 1,000 hospitals that closed in the United States in the last 10 years. And surprisingly, they were all in poor neighborhoods. They were poor white, they were poor black, they were poor Hispanic. And across the board, the ratio of this was never in the wealthy neighborhoods. It was always related to an economic downturn and an increase in the ratio of Medicaid. So we went back and started looking at our Medicaid population about net operating incomes that we got from taking care of the poor. Now, that's our mission. I don't know any providers in my hospital that refuse to take care of poor people. Otherwise, they wouldn't be in my hospital. So what's going on here? And what we found was that as an economic downturn occurs, you end up with more Medicaid and less commercial. And everything you make on the commercial side, you lose on the Medicaid side. So when the Medicaid volume goes up in poor neighborhoods, the hospital can't survive. And anywhere that there's a transition of the economics of the community, the hospitals are impaired and they end up becoming either consolidated into larger providers or end up closing. So the question then becomes is, what do you do with a closed hospital? And everybody's saying, well, you can do it for nursing homes. We had a nursing home in this hospital. The hospital started about the 1870s, and I was on staff on it when I first came to Pittsburgh. And it closed as a hospital in 2010. The community it's in was a bedroom community of Pittsburgh, about 6 miles above my hospital. And it was a support hospital for the steel industry. And as steel in Western Pennsylvania went down, poverty went up in this town and the hospital began to fail. The people that could afford to move to nicer areas, the people that were left there were poor. They were poor white, they were poor black, they were poor Hispanic, they were poor. And then we started looking at charges. The charge structure for the population was much higher than pro rata for the commercial population. So it led us back to the same place. What do you do with a closed hospital? So we decided to do two things. So we call this an experiment in disruption. On the one hand, we formed an incubator with the idea that creating jobs is a great way to resolve poverty. It sounds very simple, but it's much harder to do. And Pittsburgh has a particular issue is that we don't have a lot of place for very early companies, just above angel investors, to try out their ideas in a place where they can afford the rent. So here's a hospital. It's owned by a non-for-profit conglomerate. We're an integrated system. And I convinced the CEO of the system and of Highmark. Starts with, I have this crazy idea. So we formed a partnership with an incubator that's supported by the state of Pennsylvania. We threw in half the money, they threw in half the money, and we started renovating it, but not at hospital rates. We're renovating it Jeff Cohen rates, which are really cheap. So we can paint things, and what you find is that the people in that community, this is really their asset. So the repairs that they make to the hospital in terms of painting and carpeting, they're very inexpensive. Number two is hospitals have great bones, and probably the most important bones in the hospital are the HVAC systems. So the recirculation and the filtration makes it amenable for any kind of a BSL-1, BSL-2 type of lab. So our ability to convert an old ICU into a 10,000 square foot incubator space, and we're doing it about $150 a foot. The second part of this is that disruption hits communities, and you have assets implicit in hospitals, like kitchens and lots of space. So we went down the path of working on social determinants of health, specifically food and education. We have a school district, Northgate, which is relatively poor. And how do we affect changes in the population? So we started measuring, before you were talking about data, we found that healthcare charges are surrogate markers for the performance of a population. And you can follow these because they directly correlate to the PMPM that the insurance companies measure. And we were able to demonstrate that by feeding people, this is a novel concept, by feeding people, you can decrease the PMPM of the Medicaid population, and you can also decrease the number of times they come to the emergency room. So if you want your hospitals to survive, you got to keep the poor healthy, which is completely different than what we've done before. But I approach this through an economic lens through healthcare, not through the social justice lens. And I'm not saying that I'm right or somebody else is wrong. It's just it's really hard to get things done. And what we want to show is that we can give people a chance to achieve what they want in life by doing basic things like feeding them, finding them housing, educating them. And that's our approach to this problem. So it's a little bit different, which anyone that knows me knows that that would be typical of how I would go about it. But it's actually showing real signs of success. So I'll stop there, Michael.
Yeah, that's great. Thanks a lot, Doc. I mean, I want to talk so much more about this, and I think what we're going to do is set up a longer interview where people can join and talk more about this in detail, specifically the work that you're doing at that hospital system. I'm going to give you one question just very briefly, and then I'm going to hand off to Dr. John Dayton, who will be joining us as our Dr. Moderator. How replicable do you think this is versus how you mentioned you were getting Jeff Cohen rates on your renovations. So could we be doing this in other low-income neighborhoods, or is this something that's only specific to you?
No, as we started this program, the key to this was it had to be scalable. Mm-hmm. So the people in the building that do the labor are actually paid for by the system because they're repairing an asset that's for the hospital. So there's no additional cost at that. Number two is hospitals that close are in poor neighborhoods, so you got a great place to start. If you look around, you'll find that there's a kitchen in there that used to serve 1,000 meals a day. So, can you come up with a sustainable way of feeding the neighborhood that's poor and following their healthcare charges, which we do through DHS? The whole purpose of this, and when people ask me what I'm doing, it depends upon the people, but I want to change the healthcare system before I retire. And when you look at this, the future state of healthcare is that the provider systems are really social service agencies that occasionally operate on people. So you've got to get in front of the problem. And these social determinants are not just cute things that are toss out phrases and buzzwords. They are real factors that you can affect and follow them through the lens of a charge system within a healthcare provider network.
Excellent. So thank you very much. So let's one of our items right there is to see if we can scale your innovative system right now that you're doing out there into multiple neighborhoods across the country. That would be one thing. Dr. Dayton, what do you think of that as a potential solution?
Let me make sure my
we can hear you. There you are.
Stream close up. I think that's a fascinating idea. What I love to see is different ideas coming out of different spaces, and ultimately the goal is, all right, which of these things can we measure? And as you mentioned, where can we replicate this? I mean, Pittsburgh is not the only area that deals with these kind of problems, and so it'd be very interesting to see what kind of things can we export out of Allegheny Health that will be useful in other areas.
Right. What types of experiences have you had with the kind of decay of a healthcare system matching the decay of a community? Have you seen that yourself?
Yeah, it's interesting. I spent the last couple of years working on the Navajo reservation. So on one hand, that's a very austere environment. There's low dollars spent, but at the same time, they're able to coordinate a lot of things that work really well. For example, during COVID, the cafeteria in the hospital shut down, and people are using that space to make gowns because we were basically working in spacesuits for months at a time, and that took priority over another thing. And so it's just a matter of cost shifting and space shifting and realigning what we're using different things for. I mean, that's a simplistic example, but at the same time, that made a big difference to the patients. Another interesting thing is to see what kind of technology can we use outside of, I'm based in the emergency department. So a lot of this is based on how do we coordinate this care better between the emergency departments and the primary care offices. Luckily in the Indian Health Services, everything is matched, and we have ability to see the patient records, whether we're on the ER side or whether we're on the primary care side, and then that extends to psychiatric and dental records. That's not a universal thing. So how do we make these records portable? How are we using tools outside the hospital? For example, during COVID, folks there was only so many beds, and then our ability to admit patients got limited by the available beds and surrounding facilities. And so it became an issue of, all right, what's going to be the best thing for this patient in this community? This patient can go home, but they need an oxygen monitor. This patient could go home, they need oxygen, but do they have the facilities? A lot of these folks don't have power. 30% of them didn't have power to plug in an oxygen concentrator. So there are a lot of tools that were managed, but we tried to really coordinate the emergency care with the local primary care, with the surrounding facilities in Phoenix and Flagstaff to kind of facilitate the best thing. But as you mentioned, one of our big things is, hey, we need data, and we need to communicate. We need to use tools outside of the hospital. The physicians that are involved need to be able to monitor those results for those patients, and we need to be able to share that information.
Excellent. So I think that's a great time for us to transition with our panel as well and bring them on. So we have Dr. Cohen's solution, which is really great and potentially scalable. We have John's input that there are other solutions outside the system that we need to be able to engage with that. And with that, I'm going to be bringing on our excellent panel of speakers. I'm going to start with Dave Ochi. And the reason I'm going to do that is because he runs the Innovation Hub at CSU Domingo Hills. And one of their mandates is actually to integrate the community itself in their innovation center so that they can try to deal with innovation in the community as a paired event. David, what would you say about the solutions provided so far? What has your experience been? And what are the difficulties in trying to engage the community to do these types of things?
Well, first of all, thanks for having me, and it's great to be a part of such an esteemed panel. Jeffrey, I have to tell you, I've been a fan of the work you've been doing, and coming from an entrepreneur background, we're very used to just painting the walls ourselves, and working off of folding tables and stacked boxes as our seats, right? So, and that's not what we think of when we think of funded medical device companies with $150 million Series Bs, this kind of thing. And it just is it's a different world. And then the thing I would say to answer your question, Michael, is that we have to look at this as something that is an entire massive ecosystem. And I love the fact that Jeffrey's trying to change healthcare, right? I mean, what an ambition. And luckily we've only got another 40 years of his career in him to try to accomplish it. Right. And that time frame that we are talking about, whatever measure you want to use, a sixth of the nation's economy. This is going to be a ship to turn. And one of the things that I frequently see is that there's a lot of thought about innovation in healthcare as being devices, therapeutics, diagnostics, whatever it is, right? It's always about the treatments, and there's just not as much talk about innovating the process of healthcare. The systems are built around efficiency and excellence, right? And all the measures are around that. And yet, if you look at how startups and innovation really takes place, it's messy. And we don't like messy in the healthcare space, right? It has to be clean and perfect and precise and replicatable and duplicated exactly the way it is. Otherwise, literally, you can lose your license. You screw up once and your career is over, right? And so there's the culture of innovation, I think, is probably the biggest driver, that we have to find a way to make it so that we accept diversity of environments as testing grounds and labs for us to reasonably play in, and that what we do in Pittsburgh may not be what we do at Stanford, may not be what we do in LA, and that by allowing each ecosystem and group to experiment towards excellence and innovate, we're going to find the best practices. If we all do the exact same thing everywhere, it's your argument for we've created equity, but we haven't created innovation out of it. And so we have to find this path that we're on a path towards equitable solutions, but not necessarily having to accept that innovation that needs that messy playground to work in. And so I think the biggest one is just getting a culture of innovation. And then the other thing that was brought up in the last panel that I think is very true, when you get into some populations that have come from disadvantaged backgrounds, trust is the biggest issue. There's a huge amount of systemic distrust that we have to spend time unwinding.
That's a great point also. Thank you. I'm going to introduce our last two panelists right now. We are waiting for one more who had a little bit of technical issues. Hopefully he'll join us shortly. But when we're talking about regional ecosystems and different types of ecosystems to play with, well, here we have two members of the Utah ecosystem. So Will Walker comes from Hall Venture Partners, where they're operating out of an opportunity zone in Provo, Utah. Is that right, Will? Provo?
Yeah, that's right. Right.
And Chandana represents Altitude Labs, and she represents a stacked partnerships with a number of innovative organizations, and all the work that they're doing also in Utah in order to provide wet lab space and innovation support in their area. So with that, actually, I'm going to start with Will, and then I'm going to hand off to John to moderate from here on out. Will, what do you think about the differences between different areas and different solutions that are provided therein?
Well, I've heard so many interesting things that feed into our 130-acre campus in an opportunity zone in Provo, Utah, because literally our 70-year track record on innovation and social impact and ESG for 70 years, tangible technology is kind of acknowledged as a leader. We're kind of the poster child for HUD and for EIG and some other, government and non-government think tanks for not only opportunity zones, but for redevelopment in hard-hit areas. And, it all comes down at some point. I've heard a lot of things about jobs. I think Dr. Cohen and David both mentioned it, education and jobs and trust and all of these factors go into our 70-year history of what we've done. And collaboration too. David was starting to, really did a good job at some of the ingredients that I've spotted over my long private equity career. I'm on the money side, but Also, transactions and profits have to go in at some point to create the jobs and sustain the jobs. But the collaboration we've already had with ASU, Texas A&M, UCI, UCLA, UMass, I could go on and on. It's not just educational institutions that want to copy or joint venture, because our campus, our innovative campus, is right on the BYU, next to the BYU campus. It's 130 acres. We turned, and this is a Pittsburgh reference, we turned an old steel mill, which was the largest employer west of the Mississippi for many years, and it went into absolute total decay. And we've turned that old steel mill into employing 750 people now, 200 of them scientists, engineers, and medical talent, healthcare talent, with our own patent office on there and other shared resource systems. So that's why we really enjoy invigorated collaboration, we call it, because sharing material communication, what's working, what's not, even resources, whether it be in a healthcare project or it be in an ESG project, because we do everything from electric vehicles to, AI toilets. One of your last panels had a big deal about an ounce of prevention is worth a pound of cure, with so many people coming in from lower income neighborhoods say, well, diabetes is part of my family. There's no way I can do anything about it. But, once again, in healthcare, we're a leader in preventative, identifying healthcare and doing something about it through education and collaboration. So anyway, that's my little intro there, and I had something with steel and collaboration and all of the above. So I'll get it back to you.
Way to hit the wheel on that one. Very good. So Chandana, talking about collaboration as a way to like bringing these different groups together. I mean, it's not easy when you're trying to play the system and pull like these disparate points of view and get them to focus together. What has your experience been on that front?
So, I mean, we're, as you kind of alluded to, Mike, Altitude Lab, we are co-founded by Recursion Pharma, which has completely changed the way they pursue drug discovery using a data science platform, and the University of Utah, which is a powerhouse here for life science IP. And what we found through collaborating and bringing all these minds together is that our teams have all these experts around them to guide them about problem solving from different lenses and points of view. In life science, we tend to find a discovery and then try to fit, a square peg in a round hole and figure out which one will wiggle in enough to like make a solution of it. And what I love about what Jeff's doing and what I'm seeing some of my teams do now is actually by immersing themselves in the clinical environment, finding the problem space, and then finding the path to solution. And that really can only happen through collaborative relationships, right? So whether you build a collaborative relationship with a hospital network or a clinician, or you can get to a reservation like John gets to do now and then and see like the real problems that people and patients are going through, right? So one of our companies has done that. They took the human-centered design from IDEO, that model of doing hundreds of interviews, and they were able to figure out by just simply reformulating a simple painkiller that they can deploy that for 1/10 of the cost of the current painkiller methods that are used in post-operative pain management, And now that solution not only addresses the poorest and helps them get relief, but is cost savings for the 1%. So it's, there's so much opportunity through collaborative relationships and taking on new methods of design thinking to help the entire value chain and the entire population from the ground up. Anyways, wrapped all those ideas into one, but I love what you're doing, Jeff. I went to Carnegie Mellon and my first research projects were at Allegheny General Hospital. So like, I know exactly what you're talking about. Yeah, love it.
It's so great to have people from different spaces and also experts on collaboration. I'd love to hear more about unique things that each of you are doing. We got a little bit of a taste of it with Jeff's background, obviously things that Will and Chandana and David are working on. But I'd love to know one of the big things that we see is if something works somewhere, it obviously isn't going to work in other places. But do you guys have ways of spreading good news or good projects that you've done individually? For example, let's say you have a pilot, it works great. How do you get that news out, or how do you export that to other areas? Let's kind of take everybody one by one. If we could go, Dr. Cohen, Will, Chandana, and David.
So how do you let people know that you're doing something that makes a difference? On the innovation side, go make some money. People tend to follow that, and there's nothing wrong with making money. But a comment about making money is that crisis leads to innovation, and innovation eventually will be satisfied, and then you end up with a period of creative destruction. So what we saw in many episodes for the steel mills was the creative destruction of an industry that rebuilt the world after World War II. I look at healthcare today and I see the same process. And are we going to end up being Kodak, or are we going to end up reinventing ourselves like some of the companies are today that are legacy industries like IBM? But the innovators, the people that actually do the innovating, are not people that build devices or make drugs. The innovators are a real pain in the ass. They're the people they have an idea and they have the personality structure that they're just going to go do it. And they really don't give a damn what anybody else thinks until they prove themselves wrong. And they're the 1% of the population, the ADD kid that would nobody go away, leave me alone. But yet Durrell was one of those kids that I introduced to Mike Szymanski. It took about 5 to 10 minutes to figure out who he is. Look for the people that are different, okay? And have it solve a real problem. That's how you let people know.
It's such a great point, and it's nice to see that Allegheny recognizes your value, and even though you may be saying things that will cause disruption, it's a positive disruption. Some academic institutions are very hostile toward that. If you have a side hustle, if you're building something else, they want to control the IP, or they want to tell you that you can't do that because all of your attention should be focused on the institution. Has Allegheny, what's the environment like there? Do they have separate rules for entrepreneurs, or have you had trouble navigating that at all?
So institutionally, first of all, I'm not of the belief that the institutions promote innovation or change. They're the last meeting of the Dinosaurs Club where they all voted against extinction. So the innovation has to come from outside. It doesn't mean it won't come from inside, but it has to come, which is why we did this deal with an external incubator to bring in startup companies from CMU, Pitt, and other areas around Pittsburgh to bring me your ideas, and then I'm the connector to the clinical world or the voice of the customer. That being said, I can't imagine having to put up with me for 35 years, but I give them credit for at least allowing some differences of that 1% different person to be able to go out and make a difference. And a big shout out to David Holmberg and Cindy Endorphian, who were my two bosses. They're really great people to allow this to happen. So if you're going to do this in an institution, find out somebody that has a lot of patience.
All right, with that, perfect transition to bring in our last panelist here. Sorry, we were having technical problems even getting him on, but it was actually not on his end. It was on ours, I'm finding out. But Joseph Spence works with he founded Justice Capital, and he's working on a tremendous number of projects that actually integrate with public-private partnerships and the government in order to pursue health equity in different spaces. And he's an expert on the impact that has had on local ecosystems in terms of the socioeconomic policies. Joseph, I think one of the trends we just heard about was the difficulty to get institutions to innovate. What has your experience been in trying to get people off the ball when you're talking about the largest institution in America, the government? And what are the valuable things that they've been able to actually contribute, or what have you had to do in order to get them to see the light, so to speak?
Oh, you say that like as if it's past tense. Have they seen it? Is a wonderful question I guess we'll find out. But I would say this, in respect to the comments previously, someone has to care enough and be creative enough and calm enough to sit in the middle of the pocket, so to speak, until they figure it out and push it through. All environments have a tremendous amount of incentives all across the board, different people with different motives and why they're doing things. And particularly for innovators whose main motive isn't a 9 to 5 or that type of disposition, one has to be patient and one has to be smooth, to be able to talk to people and understand people, what their motive is, what gets them to move, and to be able to, I don't say push that button, but align with them to get things done. I think in my case, my driving passion, certainly, healthcare is part of it, but I think we had talked previously, I focus a tremendous amount on smart, sustainable cities that work for everyone. And healthcare is a key element to that when you're thinking about what a sustainable, vibrant, abundant community would look like. That's a key element to it. And so that vision, that consuming vision, has pushed me to be able to pull together a number of different parties that maybe would not have seen themselves to have been allies in particular areas, but when they understand the underlying connection between these different things in education, right, housing, healthcare, workforce development, right, transportation, all these things impact one another when done appropriately. And then you can really begin to think about ways to layer in different ways to create returns, right? So it doesn't have to all be a philanthropic focus. If you really want to get something to scale, you have to be able to get more capital to it. And so certainly philanthropy and grants and government involvement has its place to incentivize things. But if it's structured appropriately, you can make a win-win-win for all the people at the table. And that's where I think the beauty and the artistry comes in there, right? Because like I said, you're dealing with different motives. And so that conversation is going to impact different people. My background coming here, before I got in, I retired from Goldman about 4 years ago. And at that time, I was managing the tech, media, and telecom team and the real estate, gaming, and lodging team for the Americas and EMEA region on the debt side of the house. And so that naturally led to me in looking at global things around climate change to understand the integration of technology and land development and how that impacts all these different issues, and how if you're smart about it, you can really build resilient, healthy cities that accomplish all these different objectives. And like I said, healthcare and food quality, as Jeffrey was making his comment, is huge. And so, and just I know we're talking a lot within the U.S. I work directly in a number of different communities here in the U.S. and looking at public-private partnership arrangements with local and federal government. But this is also a dialogue that is an international one, just coming out of COP. They've caught the same bug around the same type of interlinked understanding about how healthcare and how all these other issues blend together to kind of create a resilient, healthy community. And this also came out of Jordan, was there about three weeks ago for the Arab Future Summit there. And same thing, same conversation. These methodologies and modalities of thinking about healthcare and understanding the interlinkages of that with these other issues is a huge topic of interest there. So, but let me just stop there. There may be questions and whatnot. I know other questions that you might want to ask.
That is a fascinating background, and it's great to get that knowledge from different areas. We're talking about how all these things involve having different partnerships and having different focus. Chandana and David, particularly, you guys straddle different areas where Chandana is working with University of Utah and has a bunch of investors and also has lab space. David, you're leading the efforts at your university. I'd love to get tips for other folks who are in academia or in areas where they're trying to make a difference and want to have collaboration and tips for moving the ball forward.
There's one point I would add just on that there as an example. Right before the pandemic happened, I had got the royal family of Norway to come out to Utah, and we did a wonderful event. We did a broadcast into the school system with Princess Martha talking, again, smart, sustainable cities that work for everyone. And we did a number of other events, a women leadership focused event at Modern West Art Gallery and a few other events. they have been a wonderful partner. They got a lot of their money from oil, right? They've made a huge pivot to focus on sustainability-focused themes. But I found both them and a lot of the other Middle Eastern sovereign wealth funds, if you articulate, and even within the U.S., right, if you articulate the value proposition to them appropriately, they are more than willing to engage. And like I said, especially in healthcare, I mean, it's a huge sector of the economy, clearly, and it's not functioning right. But I think it's ripe for disruption in a lot of areas. And so getting a lot of folk like that to be partners, and then looking at other service delivery organizations, like in our case, federally qualified healthcare centers have been very wonderful partners with a lot of the work that we do. And so the field is very ripe, I think, for disruption and for non-traditional players to get involved.
There's huge value in finding something that's worked somewhere else and say, how do we export this, and how do we work together, and who are those players? How do we make that happen? Yeah, and Shadana and David, I'd love to hear tips you have as well, and then we'll.
Sure. For all of our academics out there, or if you're, faculty / physician, moonlighting in the lab, an interesting thing that a friend of mine and I were thinking about the other day was that there is more available SBIR funding out there than there are R01s. And I think that, let that sink in for a second. So an SBIR is funding to go start something and commercialize a technology. So if you are, moonlighting in the lab still and thinking about, hey, how do I make meaningful change and impact the lives of millions of patients? There's nothing like innovation to really tap that. And there's money to do it. And post-COVID, as we slowly build towards a post-COVID world, we're blessed with an environment right now that every layperson understands the critical value of healthcare right now. And so there's never been a bigger tailwind to go do this. And so if, tips for you is that, hey, it's way easier to make a difference as a innovator right now. And we're at a particularly unique point in time. It's way easier to get the funding, to get the resources, to get the partnerships you need to go and get off the ground and do this than it has ever been in my, albeit biased perspective.
Great point. And particularly not just the SBIR grants, but there's a lot of funding right now for healthcare innovation. This is a perfect time to take advantage of that opportunity to build out your idea, to scale it, to get some data, to see where it can work somewhere else.
I echo that. I think there's a few things that come to mind. One is that we think of innovators as a person or a type of group of people that sits off in some corner, or they're over there at the innovation lab, or this kind of. That's defeating the purpose of an innovative culture. I think one of the keys and one of the things I'm pushing very hard on at Dominguez Hills is that every single person on campus is an innovator, and they all have access to problems that we need to solve in ways that we could never understand them. They are the group for us to go find problems and solutions from, right? And we spend millions of dollars every year all around the country doing I-Core study to do end user assessments of things. Yeah, and we've got, on our campus, we've got 17,000 students that not necessarily in the medical space, but they have insights into their own lives. We have to culturally find ways to extract and pull all that data from them so that we start helping people on campus, staff, faculty, students, everyone think of themselves as innovators. Because if you want a skill going into the career of the 21st century, it's be a really good innovator who can get things done. You mix those two things together and you will have a career that no one could have ever mapped. The other thing I'll throw in is, it was a great point brought up about SBIRs, but one of the things that's most fascinating to me is many universities tout how much research they do and how much federal dollars they've attained. And most of it's federal. They obviously have some corporate contracts and other state grants and things like that. But the bulk is going after NIH funds and, NSF funds, every department you can name, pick your acronym, but the total research budget and this data is maybe a few years old at this point, but is somewhere in the $150 billion range. Now, I know that went up a lot because of COVID, but pre-COVID, we were talking roughly $150 billion that everyone's chomping for. You've got every R1 university chomping to get those $150 billion. And is there more available than, yep. But what's amazing is the top 10 publicly traded companies in the world spend that much on R&D. Just the top 10. So we have universities hyper-focused on federal dollars, and yet what they end up creating is innovation looking for a problem. And that's why we have things like iCore, right? And then you flip it around and you say, but look what Amazon and, Volkswagen and all these companies, they're spending, just the top 10 are spending as much as our entire federal government. They're trying to solve problems and get it into the market, right? They're going from a problem approach. And that's why, frankly, private companies tend to innovate much better than research-based stuff coming out of universities. Universities are doing a push approach frequently and trying to make the pull come along when they've got an invention. So I think one of the biggest things is for us to allow for that randomness that comes from exploring things and seeing what we can do with inventions and allowing everyone to become an innovator and an inventor, and that be an expectation of the culture, because it's that private ownership, even if it's just yourself as an employee in a company or in a university or whatever, that will drive innovative thoughts that no one had thought of, and it creates the real value in the end. And so I think we can't take a top-down approach to innovation. It struggles a lot. I think we have to let a bottom-up approach come about, and I think that's going to require huge cultural shifts that I'll be along with Jeffrey he's going to try to innovate and completely change the healthcare system. I want to completely change the innovative culture of every company in the world. So
yeah, as long as we all
can I jump in there real quick?
Yeah, please, Will. And then I'm gonna have to wrap us. I'm sorry.
Yeah, I just want to make a few points. By the way, Joseph Spence, you're going to get my vote in the next election, because everything you got it. Everything we've done for 70 years in our Utah incubator accelerator is built from smart cities, smart homes, smart transportation, smart healthcare, and we've talked the talk, but we've walked the walk all the way down the road to profits, transactions, and big time solutions, and all of these ESG, social impact, now the hot buzzwords. And that's why we get so many people like our keynote today with Tobin Arthur, Matt Patsky, to invest in us and also help us innovate from his point of view, which is really ESG and social impact mandated. But it also comes down to profits. And the word I believe we've mended between different universities and different alumni associations around the country that we incorporate, for lack of a better description, is a blend. It's a blend of innovative talent coming out of the universities. We get more MBA engineers in the Utah area than any place else in the country, but it's not just engineering, it's science, it's healthcare professionals, it's all sorts of things, but there's always a blend between new and old, and then the profits, the transactions and sustainable traits that come from these innovative, needed, necessary things. And that's the incentive that keeps the carrot going forward and keeps the innovation productive, sustainable, and ready to go. So I just want to get that in there. I know we're running short on time, but
yeah, I'm really sorry. The reality is that if we were able to cover these topics the way I really want to, the event would be 8 hours long, not 3.5. So there's just not enough time. But everyone that likes this content, stay tuned, because this is just one part of a continuing conversation. This is the third roundtable that we've held on the subject. The fourth are going to be more solutions-based. But given where we are and the topics that we're covering, we may end up having almost a breakout session or an offsite where we spend a little more time digging deeper into these issues. I'm going to throw out a suggestion that is extremely self-serving from an AngelMD standpoint, because it seems like everybody here kept focusing on this aspect that the types of innovation required in order to solve these problems aren't necessarily startups or technology based, but rather institutional based and communication based and partnership based. And this aspect of how do we connect grant dollars that are trying to solve these problems from the socioeconomic side with the innovators that are willing to put those dollars to work in great ways like Dr. Cohen has out with the Allegheny Health Network. And seems to me that what's really needed is, I don't know, a partnership that somehow breaks down the barriers between different stakeholders in the healthcare ecosystem, like maybe an impact partnership, as it were, if I'm just going to coin a phrase here on the fly. But these types of things are exactly what we need to do, and we're going to try to draw on all of your resources to provide more content of this for our startups and our innovators and our organizational people on an ongoing basis. So thank you so much for joining us today. And with that, we're going to have to transition to our next panel. John, I know I didn't give you as much chance to talk because we had some very cool ideas going on there, and I needed to transition quickly between them. But we'll have you back too. So
it's an honor to be in the same virtual room with such great thinkers.
These guys are awesome, aren't they? Aren't they just amazing? I'm so happy. So our next one is pandemic preparation. Obviously, it's been a strange and winding road for us in terms of the last year and a half. With over 750,000 deaths in the U.S. alone and trillions of dollars of economic support going to the economy, we all can just hope if we're going to be returning to normal soon. I mean, we thought we were a couple of times so far, but let's assume we are now. Still, while vaccine technology is obviously advanced, along with testing and therapeutics, what else may we have learned from this shared experience? As we all know, the world's becoming smaller and more populated, and we need to prepare for the outbreak of the next virus. Are we? What changes or plans must we implement as a society to minimize that impact on our people and on our healthcare system? Ooh, that's weighty. Most of us, when we're talking about these topics, we can only think about being stuck in our apartment and like how much we hated the TV and all of the different hate being thrown around on social media and other aspects. But there are positive lessons we've learned from this, and there are lessons we should have learned from this. And with that, I'd like to bring out our first speaker of the day, Sarah Lynn Mark. Is Sarah Lynn here, or what, are we having difficulties? Well, I'll give a little background on her, and then otherwise we'll just move straight to our doc moderator, and we'll talk about it up front. So Sarah Lynn is an endocrinologist, geriatrician, and women's health specialist. She's been the first senior medical advisor to the Office on Women's Health within the Department of Health and Human Services. She also designed the first Women's Health Fellowship in the U.S. and helped create the National Centers of Leadership in Academic Medicine, Centers of Excellence in Women's Health, and landmark educational campaigns on critical health issues. She currently serves as a medical and scientific policy advisor to the White House, NASA, and other organizations dedicated to improving health on Earth and in space, holding 4 academic appointments, including Yale and King's College London. So as I jokingly said when I introduced Sarah Lynn on social media, is that after 5 minutes of talking to her, I felt like maybe she was dropping names, like name dropping, and then I realized she hadn't even started. Her career has been truly phenomenal. She's been all over different places on policy, but more importantly, she has a very unique view of the policy of around the pandemic and potential things that we might learn from it and what we can do going forward. Sarah Lynn, could you tell us a little bit about what you're working on now, how that applies to our recent experience, and maybe a brief insight on, but give me a positive and a negative that you saw from these past 18 months in policy standpoint.
Yeah, well, thank you so much, Michael, for inviting me. And I also want to thank AngelMD for hosting this session. It's so important. As we know, communication is absolutely critical. I often say that I feel like a broken record because I've been repeating the same messages from the start of the pandemic back in March, 2020. And the key things are that messages need to be clear. They need to be consistent with the facts as we know them, and they need to be coordinated among all messengers. I think when we don't do that, it creates confusion. That contributes to polarization, politicization, and even vaccine hesitancy. And as we've seen, it's divided our country. You gave some very sobering numbers, data. Over 780,000 people in the United States have died, 5 million across the globe. We have over 47 million people who have tested positive here. And if you think about 30 to 35% of that group who may even have mild or asymptomatic infection will develop long COVID, meaning chronic COVID for days, weeks, months, and potentially a lifetime, we've got some serious issues to talk about. For me, I have served in many different capacities. You gave a bit of my history. I came to Washington many moons ago to join HHS, and I became the civilian medical advisor to Surgeons General. And at the time, we developed the pandemic preparedness plan, and I always kept it by my desk. We thought it would be bird flu, if you remember that whole issue where we were afraid of avian influenza, and lo and behold, it became coronavirus that would cause so much turmoil for all of us. And over the years, I've just been so fascinated by public health preparedness because I think it's really giving us a snapshot on some of the issues that we need to think about in healthcare in general. And you've raised several of them today, such as the equity issues, the impact of social determinants, such as age, race, sex, gender, all of it, and the intersectionality of all that and how that comes to play. And we certainly have seen that in this pandemic. I am from Colorado, so even though I live in this crazy land of Washington, D.C., I had to go back to my roots in Colorado. And I stood up a task force, a Colorado task force of space tech companies to help companies repurpose their manufacturing to address some of the needs early on in the pandemic. And it was really, so inspiring, so redeeming that people would do this. One of our companies, Andrew Cruz, for example, I'm sure many of you in your audience know Andrew, had offered his canisters to repurpose them for oxygen canisters. So we know that when we bring together committed individuals who really want to help each other, we can raise everybody up. It's a sobering time. I'm going to look back at Colorado right now. I think we learned from case reports. And so let's look at the state of Colorado. It's rising in COVID cases. It's I think it has the 5th highest right now. There isn't a reason exactly why. Can't just be weather, can't just be people aren't vaccinated, because Colorado and certain parts of the state are doing quite well. So how are they addressing this major challenge? And I think, Michael, this comes back to that health decisions are never made against a blank canvas. We know politics, economics, the psychosocial environments shape these decisions. And I think we see this right now, even in Colorado. So what are we going to do? The governor has just issued an executive order to ensure that boosters can be provided to all members of his state because they believe they're in an emergency state. So again, boosters, are vaccines. The other is ensuring that there are more therapeutics, such as monoclonal antibodies. There's also a point of trying to ensure that people know that they are at potential risk. Now, one of the challenges that I find surprising is that we're not talking about masking. And we know masks can actually decrease spread. There's an amazing study that just recently came out of South Korea that showed masking could decrease the rate of transmission by about 95 to 98%. Yet there's such a political nature around this medical device that we dare not want to even talk about it. And we often leave it to, local and regional levels. So I think, we have a lot we can talk about. We've made progress, but we are no way out of this pandemic. And we can do magical thinking, but we're not quite there.
So, yeah, well, I was hoping you'd tell me all was clear, but I didn't expect it anytime soon. It's like the hope versus expect that thing. You mentioned something that I wanted to ask you a quick question on, and if you could just give a brief response, and then I want to hand off to our doctor host, Kate Eisenberg. You mentioned the pandemic preparedness plan. Now, this has come up a few times where we had a plan. Like, what did we do with it? Just trash it? I mean, what happened in terms of, or did we follow it and it spread a lot faster and it was just bigger than we expected to have, like a bigger effect than we expected?
Well, it's a really, really great question. And I think we heard early on that there were some challenges to the system. In order to have a robust system, you have to fund it. You have to fund it internally, domestically, as well as internationally. I mean, it's a pandemic. It's a global, joint, shared experience. And that comes back to, as long as the virus is anywhere in the world, it's going to be everywhere in the world. So that's why we've got to be united as a global community to do whatever we can to ensure people have access to testing, to vaccines, to therapeutics.
Sure.
What we also have to do, and I think it was mentioned in one of your earlier sessions, is we have to have boots on the ground. We have to have really, really rigorous surveillance. We have changed our ecosystem. Animals are living a lot closer to us that shouldn't be living as close to us. And there is that zoonotic spread from the animal kingdom into the human being and
sure.
mutate.
But I guess what I'm sorry, but I guess what I'm really trying to get at here is this: is this an issue that we underfunded the plan, that the plan was not followed, or that simply that we needed to test ourselves against an enemy once in order to get the right plan? Like, meaning that all of the planning in the world, as Mike Tyson, or more educated philosophers would say, everybody's got a plan till they get punched in the nose. Is this just a case we need to get punched in the nose once in order to find out what to do?
I think with any pandemic, we have a window of opportunity. And if you can see these signals, and there were signals, you need to mount your defense quickly. Sort of like when the horse is out of the gate, go try to catch it. And so again, coming back to, making sure that you had robust funding, you had surveillance. I think it had gotten weakened over the last few years. And partially because we felt that we had handled H1N1 very well. If you remember that, swine flu. So we I think, got very humbled very quickly here, but we had a window of time. Now, would that have changed the trajectory? I can't say for certain, but I think what it would have done was allowed some communities to scale up so that we could have mitigated death and the disability that we're going to see.
Excellent. Dr. Eisenberg, what do you think from your personal experience of what you saw as things were coming along? Failure of planning, failure of response, not a failure. I mean, there's arguments to be made that we just needed to see one of them in order to figure out what was going on. What's your take on this?
Yeah, I hear you. I feel like most of this was probably predictable. The timing wasn't, but in retrospect, as the pandemic proceeded, there were, lots of word coming out of, oh, this group, that studies zoonoses said it was only a matter of time before something like this happened. And I think we all know that the underfunding of our public health infrastructure, maybe we can get away with it for a certain amount of time, but those gaps became really clear, as things proceeded. And then from my perspective, as a family physician on the ground and as an epidemiologist, early in the pandemic, I knew how this looked like it was going to play out. And it was a very strange place to be because that's not the messaging that was coming out. So there was this real dissonance for me between my own kind of personal synthesis and recommendations and thoughts and what I was seeing in the news and what I was kind of hearing. And so I have a lot of people in my own practice and in my circle and in my health system where I was really the first one to tell them, this is going to be a thing. This is coming. Hey, I bought a Costco membership 3 weeks before anyone else even thought. Like it was, and then I started.
You're the one that took all the toilet paper.
That's right. I personally took all the toilet paper. I did some early research on health disparities. It was very clear to me this is going to exacerbate any existing disparities. So from my perspective, with adequate resourcing and planning, I don't know that it would have gone perfectly, but it could have gone better for sure.
Now, when you say resourcing, I mean, I don't want to, this isn't a political issue, and certainly the response profile has been politicized enough already. But it sounds like, from what both of you have said, is this was a response function. I mean, Monday morning quarterbacking is always easy, right? So you can always say we should have reacted sooner, except you don't want to react in panic to everything that comes along. Like if we'd shut down the entire economy for H1N1, that would have been an overreaction, right? Or SARS, that would have been an overreaction. Swine flu, that would have been an overreaction. But, swine flu was H1N1. But anyway, the point being that if we'd reacted strongly to each of those, it would have been an overreaction. Here we had a case where we didn't react fast enough, and in reality, we caused a problem. Maybe that's a lesson that we need to learn, is what the discerning differentials are between these different signals. With that, I'm actually going to be bringing on some of our panelists and handing it back to you, Kate. I'm going to try to do a group intro so that I don't have to keep talking over our hosts so often. First off will be Mike Raymer. Mike Raymer actually worked with us at AngelMD for a while before heading off to incredibly great pastures at Proficiency, where they do some remarkable modeling and other aspects. Mike has a 25-year experience in the industry, including stints at both Microsoft Health and GE Healthcare. Mike also worked on a project trying to repurpose and revitalize respirators during the height of the medical equipment shortage. We also have Rob Smith. Rob Smith is a tremendous healthcare policy analyst from Capital Alpha. Capital Alpha primarily covers policy analysis and consulting for the Washington, D.C. area. I met these guys when I was working in the hedge fund space for all the amazing research work that they do in terms of understanding what policy is driving, what's going to pass. Like, you want to know whether Build Back Better passes, these guys can tell you ahead of time, a week ahead of time, knowing exactly what's going to go on. Further, you want to know what different types of compensation elements or how things are changing in Medicare space or payables or other things. You know what? If you're an investor in this space, this is the kind of information you probably need to know in order to properly plan your investment cycles. Finally, we have Sean Dufford. Sean Dufford was a frontline commander, so to speak. He was the chief medical officer for, I'm going to get this wrong, whether it's CSL or CLS. Sean, could you give me the organization again? I don't have it in front of me.
SCL Health, Sisters of Charity of Leavenworth.
It's a charity. Thank you very much. Could you guys turn on your video if you would, if that's possible, if assuming you're not in your underwear or whatever it may be? Give us all a smiling face to communicate with. Thank you very much. And so these guys all have personal experience in their relative spaces. With that, Kate, I'm going to hand it back to you and allow you to have a discourse with these remarkable individuals.
Yeah, absolutely. Well, I'd just love to get everyone's, just to start your brief individual take on the same question that Mike was asking up front. What, how did things go from your perspective and in your different takes on the pandemic in terms of preparation, response, things that you think could be changed for the next time without overhauling things, and maybe things that would require an overhaul. So kind of those initial big picture thoughts. And let's see, Rob, do you want to start?
Sure. Yeah, happy to. Thanks for the question, and thanks to Mike and AngelMD for having me today. I think that Sarah Lynn nailed it. I mean, we had a plan. And we obviously have, agencies that are in charge of being prepared for these types of events. And we were caught flat-footed in a number of ways. And I think one of the issues there is that, we tend to sort of go from, the policymaker perspective, we kind of march from crisis to crisis to crisis. And once a crisis is over, or once an issue has been addressed, we kind of go back to, going about our business, whatever that may be. And then from the congressional standpoint, I mean, we really kind of look at them, I'll put on just sort of lay my DC cynicism out here. I kind of look at Congress like a golden retriever in a room full of tennis balls, kind of waiting for one of them to start bouncing. And until a crisis is imminent and until that ball starts bouncing, they really tend to, just kind of sit there and kind of doze off. So we were caught flat-footed. I think a lot of it had to do with, funding. Public health had really suffered, whether, you look at sort of CDC on the national level or public health agencies at the state level. The Strategic National Stockpile had gone through several rounds of cuts under some of the fiscal austerity we went through and sort of the, 2010 through 2018 time period. And really, there just wasn't much of a focus on these types of events. You also have different, views from different administrations. Whereas, the Obama folks, they came in and they were, really focused on some of the more sort of natural disaster aspects of what ASPR, the Secretary for Preparedness under HHS. That they're also in charge of preparing for, and then also, the Strategic National Stockpile. They're really focused more on sort of the natural disaster type aspects. And then the Trump folks, I mean, they came in and it was almost, right at the beginning of the administration when this outbreak started to occur. So I don't think that they had much of their legs under them then. You'd had, several different HHS secretaries at that point. So I think it was just, poor preparedness all the way through, lack of funding, lack of focus. But I think we have a real opportunity here, while that ball is bouncing, to try to assess what went wrong, what we need to do, how we can better fund these operations going forward.
Absolutely. Thank you. And maybe we can get someone else's take from their perspective living through the pandemic. Sean, would you like to go next?
Sure. I didn't know I was going to be surrounded by so many Coloradoans. So it's almost like this was planned. Like Michael said, I was more front lines, and I'm still doing incident command. And as Sarah Lynn said, we're in the 5th to 7th highest state right now, and we just enacted crisis standards of care for staffing this week, just because we're so overwhelmed. I would say we were, I agree with everything that's been said. We're flat-footed. There's a lot of policies that are made by individuals, somewhat seeming like in a vacuum. But one thing we forgot was Ebola. All that preparation we had around that, in addition to H1N1. And even those didn't, prepare everybody. And I think, everybody kind of thought something was going to happen, but nobody had an idea of how big it was going to be. I think on the positive side, though, was our ability to be a lot more nimble than we'd ever seen ourselves, especially at a healthcare level. Kind of like Sarah Lynn was talking about, seeing different industries. We had Hunter Douglas, the blind company that's based about 2 miles from us, that switched over all of their production to N95s in a very short period of time and stuff. So there's a lot of people that came to our aid. Our ability to shift resources around, especially around data, that was the important thing for us to suddenly have the ability to monitor all the event settings and categorize people in case we ended up getting into crisis standards of care and figuring out who would be a candidate for event or not be event. I think one of the most helpful things that we saw in Colorado was the gathering of the chief medical officers and chief clinical officers with the governor on a weekly or biweekly basis through the surge of the pandemic, so that, one, we knew that all the healthcare systems were kind of on the same road, not too far ahead, not too far behind, and trying to not hit the guardrails. But that allowed us to make sure that nobody was singled out by the media as doing something that was way out of whack. It also allowed for true operational input into what the governor's office and the Colorado Department of Public Health and Environment were going to enact. We had the opportunity to inform some of those discussions and decisions ahead of time, as all the health systems, and we basically had 95% of the hospitals in Colorado represented in those meetings with the governor. So the ability for them to learn and for us to head off a few things, there were still a lot of things that didn't make sense. There's still a lot of gaming between systems. There still are. We enacted our tier 3 of statewide transfer center that takes away the consent of patients to be transferred. So there's a lot of things that are still going on that we've had to figure out. But I think that ability to interact with the policymakers, at least locally, made us probably a little bit more nimble than we would have been. I think the lessons we've learned here will definitely be carried on. I don't know that we're going to need to revamp too much after this, other than to know where the nimbleness comes in. And hopefully we don't get to crisis standards of actual care anytime soon.
Yeah, absolutely. I know I saw that within my own state, New York, and my own health system, is that we were functioning as a unit in a way that there really hadn't been any impetus to before, or, there really wouldn't have been the ability to coordinate across health systems in that way, in terms of data sharing, in terms of coordinating who's getting what care, where, when. And some of that has, been rolled back as it hasn't been as necessary. And some of that is here to stay, and I think in a really good way. And then Michael, could we get your take as well?
Sure. I'm going to kind of start back at 2005 with SARS. So at that point, I was leading global strategy for GE Healthcare, and we saw the event take place in Hong Kong, and we were very concerned. And so at our strategic planning sessions, I brought the lead physician from Hong Kong into the discussions. It's very fascinating to hear how they used both the combination of community health platforms and actually software used to detect crimes and look for patterns to identify what the source, and they had the killer tower in Hong Kong, etc. And what shocked me, we got to the end of it, and I said, well, how much work have you been doing with the CDC? Has the CDC reached out to you? And the answer was no. So here I was with a multinational corporation, non-MD, but I saw the impact that this had and how important that would be to study that incident and understand what its impact may be here in the United States. Yet the policymakers at that point were really asleep at the wheel as it related to STARS. So then you fast forward to the early days of COVID, and of course we all heard about the absence and the lack of ventilators, and Governor Cuomo was indicating they needed 30,000 ventilators allocated to the state of New York. And I actually have been involved in the procurement process for the stockpile of ventilators that were kept at the national level. And one of the odd things in the spec was that the ventilator could not start unless the battery was fully charged, which us in industry said, this is a bad idea, because if these things sit around for a while and they discharge, you could still use the ventilator if it was plugged in to an outlet, but to actually not allow it to boot because of the battery. So when we heard that none of the ventilators worked in the stockpile, every one of us involved in ventilation were like, yeah, we're not surprised at all. And so then we heard that we were going to get General Motors and other companies to manufacture ventilators. So I reached back out to the team I was involved with, created the first microprocessor ventilators. And we got on a conference call, and basically we decided to found a startup and a not-for-profit called Covents. And the purpose of Covents was to take all the ventilators that were stashed in closets around healthcare around the country and refurbish those ventilators for use for ventilator hotspots. So we ran that not-for-profit for about a year. We were funded actually by one of the families here in Colorado, gave us the seed capital to go out and acquire the first tranche of ventilators. But we were able to intervene and save thousands of lives while ventilator production was being ramped up by the ventilator manufacturers globally. And it was really a great opportunity. Many of the people on the team had retired. So quite frankly, they were all sitting on the sidelines and very anxious to use the skill sets that they had developed during their career. Today, I work for a clinical trial company that does simulation training. And so we were involved in a number of the vaccine trials. And, one of the things I think we have learned from the pandemic and being now deeply embedded in the clinical trial industry, it's just the speed at which the vaccines were created. No shortcuts were taken, but really applying those lessons to all the other promising therapeutics coming down the pipeline. So, one is, I think this time it was such a slap in the face. We will learn. We'll study what we did. Two is, we'll be smarter about how to manage a ventilator stockpile. It quite frankly had never had to be tapped in the way that it had to be tapped for this project. I think we've learned our lessons from that. And then third, I'm actively involved today in a number of trials. In almost every one of them, we talk about, how can we safely move this trial at a faster pace? How can we avoid, any kind of deviations on the protocol? How can we better train site investigators? How can we more timely recruit patients? And so that's kind of my holistic view, starting with SARS and then also kind of looking at the vaccine side and in between ventilators.
So let's just, and again, we have 10 minutes here before we have to wrap this up, this session up. So let me just redirect, and I'm going to allow and then toss it back to Kate. Pulling it back together, let's try to focus on a little bit of maybe what have we learned but not implemented, or what we should have learned but really didn't, and what innovative types of things that we could do. How can we engage either innovation or changes in policy or other types of things in order to enact those lessons we should have learned but have not, or don't appear to have? Robbie went off mute, so it seemed like you wanted to jump in on that.
Yeah, no, sure, happy to. No, I like Mike's comments about data and clinical trials. I mean, I think one of the things that's going to come out of this is, I mean, the FDA is absolutely awash in real world evidence because, I mean, you look at the vaccines, you look at the therapeutics, you look at the diagnostics that have come out under EUAs with very little, they didn't cut corners, but I mean, there's a very accelerated timeline. There's, at least for, the vaccines, there's been very little done on sort of the pre-market clinical side. So a lot of this is going to have to do with post-market monitoring. How do you use data that's collected in EHRs and other sources in a way that's clinically meaningful? So I think that that's going to really, that policy, you're going to see that really accelerated. FDA has been kind of working on policies around that over the past several years, stemmed from the 21st Century Cures Act. But I mean, this is like a real world, oh my gosh, we have to use this and we have to use it in a meaningful way and we have to use it quickly. Also, I mean, just to touch on vaccines again, I mean, that public-private partnership was something that we haven't, I mean, perhaps outside of the military, we haven't really seen used on that scale and with that success. So right now there is a proposal sort of making its way through Congress to have some of that same kind of direct engagement, whether it's through NIH or BARDA, where the government partners with a company directly to try to translate, some of the basic research that's out there now to actual therapeutics and sort of bridge that 20-year gap that it usually takes in between those products. So I think that was a really great. The vaccines provided a really great sort of proof of concept for that, and that it can work, and the industry can kind of trust the government in some instances anyway to be a good dealer with that. So I'll leave that there so we have time for the other speakers.
And so, Michael, I want to talk about disaggregating data, and I think that may contribute to decreasing vaccine hesitancy. A lot of folks have said, hey, it came too quickly, these vaccines, and as we just stated, the public-private partnership really accelerated the process at quote-unquote warp speed. And again, corners weren't being cut, but the public just needs to be reassured. We have a treasure trove of data, and I think we're at a point now where we can really begin to disaggregate the data by social determinants, which can help lead us more towards precision innovation. And we've started to do that. For example, vaccines for children are at 1/3 the dose right now. So we realize that we can have immunogenicity at that dose with decreased reactogenicity, meaning side effects. And I want to take it perhaps even to the impact of sex. We know women have more robust immune systems. They also have more side effects from these vaccines. The issue of pregnancy certainly complicates it. And I think it would reassure, for example, women if we really looked at the data and saw what is the best dose that can be given in regard to vaccines where you can get the best effect and less side effects. So really taking more of that gendered innovation approach into precision innovation, I think will make a big difference. And again, I'm just going to come back and end with the issue of masking. It's just such a simple tool. It's so cheap. And yet a lot of people are afraid to wear it or it's uncomfortable. And we know masks, for example, do not fit women well. Over 100,000 deaths around the globe are in health professionals, and a significant portion were in women. And if we can redesign masking, our mask, our personal protective equipment, which we also saw during Ebola, I think we'll have great gains. And that leads us, again, into very simple steps towards precision innovation and bringing the public along with us, that we're really looking at their needs.
Absolutely. And Sean, I wonder if we could hear from you as well, and any reaction to thoughts on masking or kind of, as someone leading a health system, disseminating that type of innovation.
Actually, I'm going to kind of go in a different direction, kind of like based on what Michael had talked about, and that is being fast enough in finding alternatives, because we can't prepare for whatever the next shortage is going to be. And just, simple masking, it took a while for people to convert supply chain and industry to that stuff. I actually hadn't heard of the stuff that you were doing, Michael, with old ventilators and stuff like that. That's interesting because, all we could hear about was, ramping up supply and stuff like that. So if there was one thing I would say would be helpful, would be the nimbleness of manufacturing to come in and help with supplies earlier. Are there other, we had distilleries making hand gel and stuff like that. Obviously pharmaceuticals needing to be regulated kind of limits that, but just the making of glass vials and stuff is sometimes rate limiting for us to be able to get medications. So I think the ability to transfer manufacturing to areas that are truly in need would be something that would be very helpful. Obviously, data is there, but with cybersecurity and everybody trying to make money off of integration, I don't know that we solve that one in the short term.
Let me just throw one thing in there on that, Sean. You mentioned that we did pivot a lot, right? Lots of different industries pivoted to do it. Are you suggesting that we could have done it faster and sooner? And what methodology would you use? I mean, are we saying it should be a government purchasing plan that goes out and says it, or just guaranteed purchase options? Like, how do we do that?
I'm thinking, because obviously when everything's closed down in China, there went our gowns and our gloves and our masks and everything else. I think we weren't fast enough in seeing the private sector. I would, if the government could move faster and could coordinate that stuff, that would be great. But the greatest ability we saw to change came from private industry.
Right.
And I think that's what's really helpful.
How do we incentivize that private industry change? Like, that's what I saw too. We saw college kids who happen to have a 3D printer in their shop printing out like masks for people. We had a lot of different people switching their production lines. You mentioned the distilleries. Like, are we going to expect that the government is going to be more nimble than private industry to incentivize private industry to spin faster? Or do we create is there some other incentivization scheme that we can put into place? So they say, look, when a shortage occurs, we will guarantee X amount of production or that X amount of purchasing from you. So you can then finance a change in production. Like, I'm proposing a financial alternative, right? Where you say if you have a pre-purchase thing, then you can leverage that pre-purchase for funding to switch your production line. That'll give you the security to move.
So, Mike, with the Defense Production Act, that actually helped to do that. And as you saw it, when it was stood up and really energized, it made a big difference.
So Sarah Lynn, yeah, great. You know all about that. Then what could have been done better, or did we do well enough? Like, did that work as intended, or is it just a speed of government issue?
It needed to be accelerated. We had the tool, we had it. We just needed to expand upon it. And once it was, reactivated, it worked. So it's being aware that you have this very powerful mechanism. And, again, it's short term, it's not permanent, but it gives an opportunity to fill in the gaps. As we heard, we had shortages in our supply chain, as we have right now as well.
Yeah, I think the other thing that we're all feeling painfully is just supply chain. And you think about how healthcare systems today acquire products. They're really run through 3 to 4 group purchasing operations here in the U.S. And the reality is they need to put a greater emphasis on supply chain sourcing domestically and be willing to pay a little higher price for the assurity of supply in the event of another pandemic. But just in general, it eliminates the bottlenecks that we're seeing now in Long Beach and other ports and containers around the U.S. as we try to get supplies here. So realize it's not a decision that 5,200 hospitals have to make in the U.S. It quite frankly is a decision that's concentrated in 3 to 4 entities here in the U.S. that need to take the lead on how do we think through supply chain as it relates to the most critical products that healthcare systems need to deliver. I know the surprising thing here in Colorado, I'm very involved with the strategy on the Colorado Dental Association and working with their executive director. And the governor issued a mandate, allowed dentists to start practicing, but no one had any masks for the dentist to practice. And they had asked every dentist to give their masks to healthcare systems to be able to take care of patients. So, the reality is that I find at times some of the policymakers are not grounded in the reality of actually what's happening in the healthcare delivery system. I even experienced that a little bit in Colorado because when I would try to work with the governor's appointed official, they're a politico that had no background in healthcare. So I think that's the other thing we need to be careful about is making sure that the people that we're putting in the most responsible positions for determining public policy in the event of a crisis is to make sure those individuals are well grounded in what actually happens in healthcare and not so worried about the political consequences of the decisions that they make.
Or at least the very fact of putting the processes in place should engage the healthcare professionals themselves in terms of creating the processes that way. I mean, I think most politicos would argue that they did. They just didn't do it enough. They didn't have enough the right individuals. It's like, all right, so this is something we can learn from in terms of a policy aspect. Rob, I'm sure you and I can have a conversation about the reality of Washington, D.C. and whether that's even possible. And I wish all of these conversations could last longer because, frankly, I'm loving it. But unfortunately, as I've had to do with every panel, this too must come to an end. And I want to thank all of you for joining us. And I really hope you join us again for a recap. More and more, I'm realizing I'm just going to want to do a separate evening with each of you guys and have a long content-driven conversation that, you know, I'm going to have to figure out some way to pay you in beers or something else. I'm trying to get them to pour through the grill here. They don't come out the other end, unfortunately. But thank you so much for all of you. And with that, I'm going to be moving on to the digital divide. So bridging the digital divide. What does this mean? Okay, it seems like we were trying to think of catchy names to a lot of our sessions, and this kind of fell into that gap. The idea is really simple. Digital innovation is running breakneck in so many ways, and yet the number of times that I've seen a digital innovative solution come across my desk as a company or a startup, and then they say, look, clearly they even have the data, they have whatever it takes in order to prove that they would be a positive influence on the system, either patient outcomes or reducing costs. But their ability to penetrate the healthcare systems in terms of implementation is being held back. It's a huge hurdle for adoption based on the fact that the systems themselves don't want to adopt them. The purchaser, the hospital system, the doctors, whatever, they won't adopt it. And the question was, what is the cause of these hurdles? How do we de-risk that decision-making process? For that matter, should we? Is it a problem that the innovators themselves are not pursuing solutions that are attractive enough for the adopters? Or is it a case of the system itself? Or what can we do in order to ease this method? So the first of my speakers is Ed Miller. He comes from the Center for Medical Interoperability. This organization was funded specifically to figure out why different sandboxes won't talk to one another, right? I mean, it's essentially like why my RCA cables on my TV don't fit into my VCR if I have to move healthcare systems. But it also has expanded a little bit into the health record space as well, I understand. And maybe just a little bit of background on what the problem is in terms of interoperability and how you guys are trying to solve that.
Yeah, thanks, Mike. It's a pleasure to be here. And just to start, I'm impressed with your endurance and the way you've been able to go through session after session after session. But it is a pleasure to be here. And just to provide some background on the center, we are a nonprofit collaborative R&D lab that was formed by hospitals and health systems to really advance the state of interoperability in the industry. And we were really formed based as a result of what was proven to be a preventable medical error in a very acute episode of care in an ICU. And when the team back then at West Health diagnosed that, they discovered that the patient was in a room. There were 13 different medical modalities connected in and around that patient. And all the data needed to treat them successfully was in the room, but unfortunately it wasn't orchestrated. And that led through a series of steps to the creation of the center, and the model is pretty simple. We would bring together the users and the procurers of digital technologies for healthcare and align them around a technology architecture and interoperable interfaces that are agreed upon by the companies that provide the equipment. So we set about that mission. We developed a lab. We brought in 40 different vendor companies. We demonstrated the feasibility. We launched a certification program, and we discovered that just getting the things interoperable, and our model is connected, interoperable, and trusted. Just addressing that didn't really solve the issue. And we identified certain patterns of what was happening. A vendor would say, well, I can share data, but I don't want to share data with this company because I'm afraid, I'm concerned about what they'll do with it, or, I'm concerned if I share this data, will it be misused? Hospitals say that, I want my equipment to be interoperable, but, I have this legacy issue. And
well, I mean, let's get to that point.
Yeah.
So there's a reticence on the players in the market to work together because they're afraid they're giving up their competitive advantage, or is it just paranoia? Has there ever been a situation where that actually happened? Because I can think of lots of other things in my world where they operate with one another. I mean, even Microsoft and Apple eventually got along in terms of software designations, right?
Yeah.
I mean, but it took government action in a lot of cases. What's the answer here? To convince them that it's like we just need to do a mind warp and convince them it's in their own best interest?
Well,
or is it regulation?
They're all conflicted. So on one hand, they want to interoperate, and the vendors were remarkably supportive. On the other hand, it is a complex ecosystem, and just achieving technical interoperability doesn't solve the problem. So the way we've described it is that what is lacking is really a system for trust. And I've been really fascinated by how many times the word trust has come up in the sessions today. When you look at the barriers to interoperability in healthcare, you realize pretty quickly it's not just the technology. It's the clinical use of the technology. It's the underlying contracts. It's the financial.
Yeah, but I mean, we've been through this. I mean, let's be realistic. When you talk about, one of our doctors made a great observation that if you go to a cocktail party, everybody will tell you what their medical problems are, but no one will tell you what their financial situation is, right? So clearly, the individuals in America actually guard their financial privacy a lot more tightly than they guard their healthcare privacy, and yet we have a way of creating interoperable financial instruments. I mean, it seems to me we have misregulation in that sense.
Yeah, interoperability happens pretty well in a lot of other industries. I came from an industry that was completely interoperable, and that was achieved.
Sorry, tell me a little bit about that.
Oh yeah, I came from the cable television and telecommunications industry.
You want to talk about regional battles between people that literally hate each other or acquire each other based on the smallest differential in outcomes, right? And they manage to work together, and we have one plug that goes into my TV.
And broadband is the same globally. The technology that drives broadband in your home in the United States is the same as the technology that drives broadband in Europe and Asia and everywhere else. Because they were able to agree and align on an approach. And in healthcare, it's been the non-technical barriers that have really been the challenge. And aren't.
It would be like if my Apple mobile phone couldn't call a Samsung, basically.
Yeah, that would be kind of the outcome there. Yeah. So we've come to the conclusion, and this is what we've been working on in the center, that just dealing with technical interoperability is not enough, that the industry needs to really align on principles of trust that get to the non-technical factors. There are 6,000 hospitals in the country about, and there are 6,000 different ways of doing things. And what happens to an innovator, a startup company, when they come into healthcare is they have a technology idea and they do it with the hospital, they demonstrate it works, and then they go to another hospital and the integration is all different. So more and more of the resources go into integration and a one-off integration with each deployment, and it basically uses up the resources. So it's very difficult to get over the hurdle. So this really is a scaling issue. And the goal is to create some templates and models so that it doesn't have to be invented every time, which is what happens in healthcare.
So I mean, we have like the basic interoperability, the my sandbox versus yours kind of problem. Then we have the operational insecurities or issues with all of these hospital systems that have been built on essentially bespoke backbones, digital backbones. Then we have the electronic medical record issues in terms of different systems that you may apply there. and then
Right.
they've all been integrated into their system. We're essentially like 30 years ago with bespoke computer systems every time you wanted to build out an office building, where you had to do a massive cutover from one telephone system to another, because no one used the standardized solutions or out of the bucket solutions. With that, I'm actually going to be bringing in our doctor panelist for this. Sindhu Pandit actually comes out of Salesforce. So she has some small amount of understanding about software and interoperability and how you build a middleware platform or a standardized platform that you can still provide bespoke solutions on. But importantly, she provides medical advice to them in terms of how they're trying to integrate different systems. Isn't that right, Sindhu?
Yeah, so thank you so much for having me, and it's been very interesting to listen to you, Ed. I am a practicing PM&R doc based in New Orleans, and I'm a clinical lead industry advisor for Salesforce and their HLS practice. So happy to be here and happy to participate in this conversation.
So from your standpoint, interoperability is one problem, but there are other problems out there as well. Maybe you can deal with that and then kind of merge into what the other problems might be, and we'll bring up the panelists afterwards.
Yeah, I mean, I think Ed hits on a lot of really important points. I think we were able to accelerate some of the adoption in this last couple of years because of probably more regulatory and policy changes than anything. To his point, I don't think a lot of the technology is new. I don't think we had a shortage of data before. I don't think it was even the capacity to utilize the tech that was out there. I think it was just breaking down some false barriers that's been put up over the last, as we've grown as an ecosystem, and we had to work over them, through them, around them to get the work done. And it was a lot of, I think it starts there. And not to mention that the other portions are not important, but I think having a national strategy in which you're approaching data exchange and sort of leveraging the data for, kind of the greater objectives in healthcare is a really important place to start.
What about the actual solutions themselves? I mean, have you seen problems with adoption of digital device or digital solutions simply for non-interoperability issues?
Yeah, I mean, we're talking about the digital divide here, so I think the latest stats I've seen out of the Pew Research Institute were, I think 97% of Americans have a cell phone, not a smartphone. But it's really interesting if you look at the map of where, kind of where this is, if you look at the map of areas that you do have pockets of cell phone deserts, if you will, or smartphone deserts. And I think 15% of American adults use their smartphone as their primary way of accessing the internet. So they don't have broadband at home or broadband access. And again, if you look at the map, these get concentrated in particular areas. So on one hand, to Ed's point, you have the systems trying to integrate and be interoperable and kind of leverage data and whatnot for better insights and better action. On the other hand, we have to be very mindful of those that we are serving and how they are consuming the healthcare, and to remain smart and have tight feedback loops on that and what's working, and maybe perhaps where we're missing things, and to ensure that we're mindful of any bias that might be coming about in how we're delivering some of the care.
And of course, this gets us back to the issues of healthcare equity and the aspects of access as well.
Yeah.
That frankly, broadband is still an issue, and is actually a key determinant of health, is whether or not you've got broadband, as we learned in many different times. All right, I'm also going to bring our two panelists on. So Aditi Joshi. Aditi actually is one of our clinical advisory board members. She's an expert in telemedicine and other aspects of what's going on. Sindhu as well, of course, is, but Aditi is also a clinical advisory board member. And but she has deep experience both at the Jefferson Healthcare System as well as a number of other places. Currently, you are are we allowed to talk about your responsibilities?
Sure.
Okay, so please just tell us a little bit about your background, and then we'll talk about Ruby as well afterwards.
Yeah, sure. So I used to work at a startup and then an academic medical center in telehealth. And so I have a lot of that experience of trying to integrate into health systems and then being on the health system side itself. And currently I'm a telehealth SME for a company called Panda Health. And the whole idea is looking at the entire spectrum of various pillars of digital innovation. And I'm on the telehealth one. And looking and trying to create a portfolio so that health systems can have a good idea of what is out in the market. So it's been a fascinating experience just having these conversations on all of these sides. So excited for this conversation. Thank you.
Excellent. So Ruby Galarab represents MDisrupt. Now she's coming at it from a slightly different point of view, an extremely valuable point of view in my mind. They work with startups that are in the digital space and attempt to try to solve problems for them in terms of getting them into these hospital care systems. And so she's very, very aware of all the pushbacks she often gets from these systems as to why they say no. So Ruby, give us the top 3 reasons why adopters say no, we don't want to do that.
So good to be here, Michael. This conversation has been so good. I've been listening to it for nearly 3.5 hours now. It's fascinating. Thank you for the introduction. So I'm Ruby. I am the CEO and co-founder of MDisrupt. I have been commercializing health products for 24 years. And in the last 5 years, I consulted for 25 digital health companies back to back. And I discovered a few things about the market. So one of the things I discovered is that many of the founders who are founding these companies do not actually come from a healthcare background. And the issue with not coming from a healthcare background is that there is a formula to how you develop, commercialize, and scale a healthcare product. And it's also a very highly regulated industry. And you're also talking to the most skeptical audience in the world, right? Physicians, payers, health systems, every stakeholder in health.
Why are they so skeptical in your mind? Like they're just all paranoid? They've been drinking bad water, or they have a reason to be skeptical?
No, the skepticism comes from the training. Most of them are scientists and doctors, and that is actually how you are trained, to question everything and to ask for the data. Show me the data needs to be a really key mantra of digital health. So when I speak to health systems and payers about digital health, nobody disagrees that healthcare needs a digital transformation. The problem is how we do that. And the problem that they tell me is there is so much digital health being thrown at employers, health systems, and payers. There's almost saturation. And there is no place that any of us can go to figure out what is good and evidence-based in digital health. That is literally missing from this industry. And so what they say is, well, we either ignore some of these companies that come to us because we don't know who they are and what they do, or they say we make them do pilots and only the fittest companies will survive. And that's kind of terrible on both sides. It's terrible for the health systems because they're missing out on huge opportunities with great products. And it's terrible from the industry side because they just can't get the traction through the door. I have a lot of things to say about this topic, but I'll stop for a second and let other people speak.
Not at all. I'm going to hand it off to Sindhu now, since she is the co-host here, and allow her to kind of direct the traffic from this point on. Please take it away.
Well, I kind of want to keep hearing more here, and I want the others to chime in. I think that's a really important point. A recent something that I read said employers are now dealing with up to 16-point solutions to manage health and wellness for their employees. I can't even imagine the point solution overload that these employees are facing. So even if you're having an ailment that could benefit from one of the solutions, just that exchange is hard. And then, of course, if you expand it to what's happening in the larger ecosystem, as a provider who treats a very vulnerable patient population, I don't know how to help sift through what's available and then, matrix that with what's paid for. And then, do they have access to that with regards to whatever internet access they do or don't have? So I'm going to open it up to the floor from the different perspectives that we have. How do we go about creating an environment where we can start to create that evidence-based, those insights, if you will?
So that's something we're actually doing at MDisrupt, not to be self-serving and promote my own company, but that's literally what we're going to be doing. There's two main insights that I think are really important here. So firstly, digital health companies, the best ones, have clinicians at the table in the product development, and they bring them in early and they engage them often throughout the process. So that's one of the things that I think is really critical in understanding clinical workflows, understanding how to solve problems, how to generate evidence. The second thing that I think is important is that clinicians in community medicine are actually involved in the testing of some of these products once they make it into the market. There's something missing in the world as well for the real world performance of these products. How do they work in the real clinical world outside of study settings and outside of large academic medical centers and in the community where we have diverse populations and even diverse physician populations of different types of skill sets, different knowledge bases. And I think that's the second piece that really needs to be a part of that. And then the third part is where's the centralized data set that lives on how these products perform in the universe. And so there's some of the things that we are taking on as some of the challenges in digital health at MDisrupt.
That's great. I'm sorry, I promised I'd hand it off and then step back, but I just wanted to introduce our last panelist here, Kate Berman, joining us from Kids Act. Well, she's from Children's Hospital of LA, which I'm keep trying to call Chola, but they refuse to pick it up. But anyway, so Children's Hospital of LA, but with the Kids Act program, which is an aggregation of children's hospitals, specifically looking to implement digital solutions in the pediatric care space. And what I would like to hear from you, Kate, and then I'm going to step back again, I promise, is a take on what you're looking for when you do adopt a digital solution. Now, understandably, most of you're thinking about it much from a therapeutic side of things, as opposed to from a hospital systems side of things, which are two decidedly different topics. But let's talk about this digital therapeutics and what makes you decide to try to implement one of those versus what turns your nose, so to speak.
When you're talking about a digital therapeutic, are you meaning like prescription digital therapeutic or just digital health solutions
Digital
that
health
impact?
solutions. You know better than I. You tell me what the heck I just meant.
I was like, I could talk about one of my favorite prescription digital therapeutic companies, Limbix, but I think what you're asking, is what we're looking for from evaluation side, because KidsX essentially starts with a problem first approach where our health systems tell us what problems they're facing, and then we, source and recruit startups that we think can have both a real impact on care, but also since they're earlier stage, we have to place a bet on which startups will actually, be feasible for our health system partners to work with. I have a public health background, so things that I personally always look for on the team are solutions that are rooted in, again, a real problem and evidence-based wise. So I really resonated, I think, and I don't want to mispronounce their name, but Adi put in the chat that as a founder, his experiences that inventors prefer unregulated products with faster go-to-market. It's sort of a catch-22 with our early stage companies because they often don't have the pilot partners yet or enough pilot partners or a sample size, large enough to fully prove efficacy of product. But I think at least like having something that's science-based or science-informed is something that I very much look strongly for, especially if it's impacting actual care delivery. There's, of course, a bunch of other solutions
Let's
that are more
assume
focused.
are science-based, and not just complete snake oil, because we hope that at least the startups that we go through, we demand a certain level of data and clinical efficacy proof. But there are still cases where it's like they're showing a clinical, like they actually show trials, they actually show there's an improvement, and yet people are still nervous about adopting them. Why might that be?
Yeah, that's you mean why are the providers? I think a lot of reasons too that providers are or people that are in these decision-making positions, there is a lot of just barriers to the change management side of things, or what will this look like if I introduce this to a department? I know that burnout is a huge issue right now, so I think there's this also hesitancy of having to deal with training and further cleaning procedures and further introducing new things when people are kind of trying to stay afloat. So I think that's one of the biggest challenges I've seen right now in our digital health space is like these solutions are actually have the power and the ability to democratize care and reduce a lot of burdens, but based on still the fragmented ways systems are set up and the absolute like burnout and retention issues folks are dealing with, it's a really challenging time to like introduce what still feel like novel concepts, even if they're kind of table stakes patient experience or provider experience solutions.
You also have to remember too, so I'm a physician as well. And I've working in telehealth, I've had to almost a decade, I still have had to convince physicians to do it. In that in general, physicians don't really have a boss in the way that other people think, right? So we have chairmen, we have people who tell us, you know, here's where you're going to work. Here are our research. Here's what you need to do to keep up with your CME, et cetera, et cetera. But they don't actually tell you how to practice on the day-to-day level, right? We all have to keep within our standard of care, and we learn our standard of care in our medical education, which has not changed very drastically for decades. And so when you're trying to introduce something new, you do have to show not only the efficacy that you're saying that you have the data of, and I'll tell you, even having that data is very difficult in the first place. We get pitched all the time at these health systems with very little data because they need the data by doing the research. But then also the burnout one that Kate mentioned, that's absolutely true. You just can't do one more thing, but you really have to do a lot to convince physicians that it's going to be safe, add to the quality and standard of care. And because we don't have a standardized way to do that with the way that technology has changed our lives in other ways, this ends up being part of that barrier to have that conversation. What has worked and generally does work is, one, you do quickly show that it is safe and efficacious and it does improve quality, right? There is some research that backs it up. That will change it. I think what we talked about in the pandemic and the panel on the pandemic proves that, right? That will change things quickly if you can prove that. And then two is forcing physicians to do it. That really is, unfortunately, the way that it happens. I will give you an example. When we wanted to roll out our telehealth program within our department, we were just Jefferson, we do telehealth. This is who we are. And so physicians who work there would do it. And that really would be part of how we changed the way they thought about it.
What kind
I
of
would add to
incentives-
that. Oh, sorry, go ahead.
I was just gonna say, what type of incentives are you seeing that can like nudge that behavior, actually like celebrate that type of positive change or adoption?
So I think that's a great question. I think there's no great answer to that, but I think what has happened is just necessity. And I think because of the pandemic, we've seen a lot of this research studies. I will tell you, just even from the beginning of the pandemic to the end, the amount of research studies that looked at a number of digital interventions was incredible, how much more there was. And now people are interested in this topic. We're seeing a little bit of going backward a little bit, as you do with any big push forward. But now they know that it's here, it's part of their lives, it's part of what their patients want as well. And that's a big piece too. Patients know about it and patients want it, because patient engagement is a whole other topic. But that has been some of the incentives that have done it. And the fact that various bodies have now within the medical education bodies have said, hey, telehealth and digital health are going to be big topics. Telehealth specifically has now core competencies that have to be taught in medical schools. That's huge. As far as digital therapeutics and other digital interventions, that will just be the next step.
Well, the other thing as well that adds to that as well, Aditi, other than efficacy, safety, burnout, is actually reimbursement. And so there's this weird chicken and egg scenario between the providers and the payers, where the payers don't want to pay for something until they can see the ROI and physician adoption. And then the physicians don't want to adopt it if it's not going to be paid for and they don't know how to reimburse for it. And so that's another thing that I think is also really important that digital health innovators have to think about, is what is the reimbursement strategy going to be, and how are they going to create. This is another scenario where they have to show me the data. How are they going to create the data sets to prove to the payers that this is something worth investing in?
No, I was going to take 10 seconds to say what Ruby had said earlier, bro, about getting the research on community physicians is 100% true, because it's true. Academics, they set the standard, but most of the data and where most people practice is in the community places. So that was just a really big point I wanted to just highlight as well.
Yeah, I think it was actually the same kind of vein I was thinking is workflows and kind of reimagining how these tools fit into workflows instead of just, kind of traditionally, these are rolled out and yes, you either use it or you're either using it, how move forward, but really being thoughtful about the change management aspect of this. What are you seeing, given this adoption that we've seen over the last 2 years, and from your side as well, with regards to the kind of the changes we've seen along with pulling data sets together?
Yeah, I guess I'll start. One thing for sure is that the COVID pandemic has greatly accelerated the rate of innovation in healthcare, and we've had some of our CEOs, our board is made up of CEOs of hospitals and health systems, and they've said that in 1 month they've achieved more than they've achieved in years in the past, just out of necessity. And in the conversation, it's interesting here. We talk a lot about trust at the center and the 6 dimensions of trust that you have to consider if you want to have a new innovation adopted in the health system. And it starts with the clinical and operational implications of what you want to bring in, and that's the workflow and the safety. The technology is pretty clear, but from there it's the financial, which is the value proposition and the financial model, and that's all balanced by what's the risk posture for this. The risk and liability. So there's always these competing forces that tend to complicate things, and then there's the contractual. What are your legacy contracts, and how's this data going to be shared, and what's going to happen to it? And then finally, sometimes the trump card is the regulatory and the policy implications. You always have to make sure that you're compliant with regulation, and sometimes regulation is the only hammer that seems to be able to break through the other 5 barriers. So for me, this conversation is interesting, and it's just more examples of how this is a complex ecosystem, and you have to pay attention to the details in order to innovate.
Yeah, those are great points. Ruby, your thoughts on the change management and sort of the adopting some of these solutions into the workflows as they are, as we've seen over the last 2 years?
I think one of the themes that's come up a lot here, and everybody's mentioned it, is trust. And a few months ago, I was interviewing Dr. Shantanu Nandi, and he said to me, medicine moves at the speed of trust. And that stuck with me so deeply, because that sentiment echoes across every single part of healthcare. Trust between the provider and the patient, trust between the systems and the and industry, trust in research, trust in clinical trials. And so that's one of the things that I think is really, really important, is to develop that trust. With regards to implementation, again, some of the most successful digital health companies that I see are the ones that involve the clinicians early on in the process, make them a core part of the executive teams, because they're the people that understand healthcare from the inside. They understand the problems, they understand the workflows, they understand the potential solutions, and they know how to communicate with their peers. Doctors do not want to be marketed to by sales and marketing people. They want to see what their peers are saying, and they want to see what the data says. And they, to me, are the key to solving some of these implementation challenges. You got to get in it from the point of product development.
Great, thank you so much. And Kate, I'll come to you with that question, and as well as from the perspective of taking care of, the heterogeneous populations that your system serves, and ensuring that we are balancing pilot programs, et cetera, with taking care of, making sure we're not missing out on addressing vulnerable patient groups or specific areas, or making sure that we're accounting for bias.
Yeah, absolutely. Honestly, that's something that, in our first year of the program, we weren't as stringent as evaluating. And I think that it was definitely a learning for going into year 2, that it's criteria that we absolutely want to put front and center and not just as an afterthought. I think that, certainly language and having solutions that are appropriate in terms of, health literacy language or just content that's in different languages, depending on what the solution type is really important. I also, think from like an equity and access perspective, thinking about which solutions will be able to reach certain types of people and various just cultural or social norms or lack thereof around use of certain types of technology is honestly probably only going to come about through these founders actually, work seeking out and working with these groups or having people like us try to connect them to other perspectives and things. Something that came out of our last program actually was somebody had designed a wearable for parents and providers, and he had a bunch of different personas, and stuff that we helped work with him through is, understanding different parent archetypes and maybe saying guardian or having different visuals of who those guardians and kids are and what they look like, so that when they are presenting the content to children and families, they actually look like the folks being served at patient populations, and having kind of flexibility and understanding that different households are comprised of different guardian figures and family types and language and cultural, types. So that was, I think, useful for our team to say, hey, nobody in your deck looks like anybody that's in our patient population. Like, you might want to be mindful of, or not even mindful, you might want to take action on addressing the diversity that exists outside of your lens.
So these are all amazing pieces of advice for our startups, and I'm hearing a lot of that. Like, we can create an educational video out of this panel, I think, in terms of for digital startups, what they should be doing and changing for their pitches. But if we invert this question, is there anything about the system itself that we can innovate around? Are there things that we can propose? If I was going to be a startup that said, I'm going to solve the problem for other startups, is there something that could be plugged in that you would actually say, I'm going to create a tool that's going to ease the way for digital adoption across the board? Is that even possible?
I think it is.
And it looks like your company. I know, Ruby. That's great. That's wonderful. I already did that once with AngelMD. How about for something other than our self benefit?
Well, I think the point about that is actually how we bring diversity to the table of the development, right? So it's not just physicians and engineers. It's also having diverse folks in leadership positions in some of these startups, to the point of, patients trust doctors that look like them, right? And we have to account for some of these things. And in product development, technology development, in some of these things, I'll give you an example. Wearables. Wearables use a type of green light to measure heart rate. That green light works less efficaciously on darker skin, right? When we start to use those wearables to make cardiovascular disease predictions, we're not creating equity there. We're actually creating a bigger digital divide, right? And so these are things that we have to think about in product development. And it's not just on things like that. It's even on things about how we develop algorithms for some of these products.
I'm 100% in agreement with you. I just, because we're wrapping up soon, and this is the final wrap, folks. I do want to try to get into, I guess, much like we don't want to hear that the right way to lose weight is to eat better and get exercise and go out there and change your behavior. We want a pill for it. I'm wondering, from a digital solution standpoint, is there a magic pill? Is there a software program out there that could be written? Sindhu, maybe you come in as a panelist on this one. Essentially, do we need a middleware platform that solves some of Ed's interoperability problems? Do we need a centralized database format where I can now translate via handshake all of these patient data into something that is usable from these digital operators? Give me something out there that I can say this would change things. Or tell me that I'm smoking, I'm smoking rainbows here, and I've got no idea.
No, I mean, I think we've all kind of seen some of the opportunities that are ahead of us, and a lot of that has to do with data exchange, data aggregation, and data reconciliation. It's not that there's not enough data, and we're just we're getting more and more streams of data to use and to sort of interpret at the bedside, chair side, whatever, but also just in general as these systems are moving forward in terms of operations and figuring out new reimbursement models. I mean, there's just so much happening at this speed. I do think looking at things from a platform perspective and being able to plug in devices as needed or solutions as needed, and thinking about public-private partnerships. I think there's a false barrier between public health and health delivery that needs to be looked at, and the fact that I think the points made around multi-sector engagement is paramount. I mean, we can learn so much from what's already been studied and kind of deployed in other industries, and we could bring some of those learnings into healthcare. But knowing that healthcare delivery is local and that there's cultural sensitivities and regional sensitivities we have to keep in mind, and it's that feedback loop. And so whatever platform we end up moving forward with, I mean, I wish I had the crystal ball, but whatever we end up moving forward with, it has to be a one that everyone sort of comes together on, and trust has to be at the center of it. It's sort of the credit bureau for the new world of healthcare. It's this idea that we're going to be able to have this central repository where we can pull the data together, but we really can create a 360 view of the patient, but continue to learn from it. I think that learning component is so important. We cannot just get static. It has to remain dynamic, and we're going to make mistakes, but we have to be open to that and have these really difficult conversations. This dialogue has to continue, but I can't agree more that clinicians have to stay engaged across the spectrum, but multi-sector and public-private partnerships.
Is this a question of, and I know your answer, and I'm going to shoot it down, but the problem is, it's like, I'm going to shoot it down ahead of time. Is the problem an industry problem, a regulatory problem, or an innovation problem? And here I'm shooting you down. Don't tell me all three. Tell me the one of those that you want the most of. And I'm putting it on the spot. And that's going to go to everybody here. And that's going to be our wrap question. Sorry. And I'm leading with you, Sindhu.
Oh man. I can't pick all three.
You can't say all three. No, you can't say a little bit of everything. No. It's not that kind of pizza. You get one time.
I'm going to offer hoping for leadership. I think and you didn't even give me that option, but I'm going to go with leadership.
Oh, yeah, that's kind of an opt-out, because leadership where? Leadership across all three. No.
I think you can. It's like a Venn diagram, which is one of my favorite types of diagrams.
I know. That's
but
I want you to pick one circle. That's the point.
Well, I mean, I will take the fifth on this, because I do think you need all of those entities. I really just think that this is a really pivotal moment in healthcare, and we need all of those individuals and more, all those areas and more at the table to kind of drive this forward. And there is no one group that's the problem, or the one group that's going to be the savior. I think we all need to come together and pressure test solutions and continue to learn. I know it was a cop-out.
Show me some courage. Pick one. And all three are important, but like the one that you think we need to push hardest on, is it changing industry, changing regulation, or innovating?
Michael, I'll offer.
I'll jump in. Thank you.
Yeah. I very much agreed with your question about the platform and your assertion about the platform, and Cindy said trust for that and collaboration. So what I think needs to be brought out, and it could be a for-profit, a nonprofit. We have to think about that, but a platform brought to the industry with the right governance model so that it can be trusted. Because when a proprietary company tries to solve it and they come out with their platform, which is what happens, it inherently is not trusted. And that just perpetuates the issue. So it's just another way to do it. So I would say the industry needs leadership to come together, and it's going to take some investment. The innovation abounds. The innovation really comes up with the barriers to scaling.
So we're talking about like Google and Microsoft getting into a knockdown, drag-out fight again to be the public-private partner of the system. It's like what do they call it, Jedi program, whatever, all over again. Is that what we're talking about here?
Well, hopefully it's a little bit more of a collaborative governance, because the people, the entity that need to use this platform need to trust it.
As long as we're wishing for things, I wish I was 20 years younger. So, that's as equal likelihood that's going on. Aditi, sorry, you looked like you were about to jump in there. What do you got?
Sure, I'll take your bait. So what are my three options? Innovation, regulatory, and what was the third one?
Industry, like changing the industry, the way it works internally.
Okay, so believe it or not, I'm going to say innovation, but not because I don't believe in the innovation. But I think in the last couple of years, we have seen how the rest of this industry really has not kept up with the innovation, how fast it's been going. So this is a time to really get the other partners up into the level of the innovating. Innovating is going to happen regardless. So how do we get everyone else to catch up? And so that's why I will say the innovation. But I do believe in innovation before anyone misquotes me.
That's all right.
Yeah, I think that's I think that's going to be what we need to do, because this is where we're finding the barriers, right? We have these conversations.
Kay wants to jump in on policy here, Aditi. We got to get everybody a chance.
Okay, sorry, go ahead.
Past the hour, I'm cutting people off and getting punchy.
I know I was going to say I got to go soon, but I just think policy ultimately drives the incentives for change. And like if policy isn't making kind of the common sense or the healthier choice, the easy choice, then people are just not going to be able to do it. We've even seen it with like vaccines. We've seen it with other things. Like if certain policy incentives are not at play, then like large scale population level change isn't going to happen. So I think that the interdisciplinary approach, what Sindhu said, is like the most important, but I just think policy nudges a lot of other levers.
All right. Well, good news for that is our next conference in the Impact series is the Impact Policy Conference coming your way in May. We're going to be spending these next few months trying to implement innovation changes that we're specifically directing towards family office, but we will be engaging on an ongoing basis to try to put together a policy framework in order to address these same topics. Ruby, do you have something to take us home?
I was just going to answer your question and take your bait as well, actually, which is two things. If I was to pick one of your three, although I don't think it's any of your three, I would pick the healthcare system.
Oh, give me a fourth. You're already to pick it. Just not something generic like leadership.
Yes.
That kind of applies to all three.
So I'd pick the healthcare system because everybody keeps saying it's broken. It's not broken. It's actually doing exactly what it was designed to do. We need to rethink how we do healthcare. If I was to say who is the single source, if I had to pick one, even though I believe it's collaborative as well, I would actually say it's the payers. Like how something gets paid for drives how it gets adopted. And so one of the biggest influences of the payers is actually employers, right? So I think there's an interplay between payers and employers that can really drive change.
I think that's an excellent answer. In fact, one of the notes that I take down very often around here, and now mind you, I'm coming from finance and Wall Street, so I have economic theory out the wazoo, the way you guys have medical understanding. But there's a concept of improving your price signal, right? Meaning that if you're in the desert, your price signal is completely muted because you just want water. Take care, Kate. Sorry, we won't hold you on. You got to go. But if you are walking down a sidewalk and there's 6 stores where you can buy water from, right, you can choose the cheapest one for that. So that creates the stores there have a very transparent price signal model. They know the price of the water across the street, and there's an obvious feedback loop in terms of how much product they sell based on that price signal. So we've created a very obvious price signal ability. And that's the same kind of thing that happens very often. We see it with single payer systems. We see it with issues where your insurer is being paid for by your employer. And so therefore the price signal is being swamped along the way. We see it with over bureaucratic operating systems where the people that are looking at their cost structure aren't the people that are seeing it as boots on the ground. The framework comes in over and over and over again. If I'm going to have to say that there's one overriding theme that I've heard at every panel today, it's the need to improve the price signal, whether that's in healthcare access, showing that by providing better access of preventative care and actually providing good healthcare to the lowest chunk of the population, you actually decrease the burden of the people paying for that system, and that they don't see enough price like signal strength in order to understand that that's going on. Whether we're talking about, mental health doesn't really fall under that framework, so I'll take that one out. But when we look at just about all of the others, innovation ecosystem, when we look at pandemic preparedness for that matter, the amount that you pay up front, John Nash Equilibrium would call it internalizing negative externalities, but that's a story for a whole nother time. You go ahead and Google that in and take a look. But thank you so much for everyone that has joined us today. I know it's been a long haul. I know it's been a long haul for me, and I'm looking forward to grabbing a glass of water. But I really appreciate those of you that have spent time with us today. There is a fantastic networking event that occurs after this that, as I say, it's probably the best cocktail party you'll ever be to. You just got to bring your own cocktails, unfortunately. Or fortunately, as the case may be. And so therefore, folks, thanks so much. Again, Pitch Club every other Tuesday, where we have the same type of community where we talk about different things. We're going to have roundtables and other conversations and continuing discussions about these topics going forward. So please register as an AngelMD member. Even if you're not a doctor, you can be a member. Just register. The content is directed towards doctors, but everybody is invited. Thanks again and have a great week. Have a great night.